So welcome, everyone. We are so excited to welcome you to day one of our 3-day virtual NIH Pathways to Prevention workshop on identifying risks and interventions to optimize postpartum health. Hopefully you can all see and hear me okay. We are just delighted to be able to start this workshop. As you can imagine, for a large 3-day workshop with over 35 speakers, we've put a lot of planning into this, and we're just really excited to have you all here joining us today. My name is Kate Winczek, and I'm the coordinator of this Pathways to Prevention workshop, and I will serve as the master of ceremonies to help guide us through today's agenda, presentations, and discussion. And of course, just want to recognize the large team that I have working behind me today and the next 2 days, helping to keep things running. I also want to take this opportunity to say thank you in advance to our workshop co-sponsors and planning team members who, as I just noted, have spent almost the past 2 years planning this workshop. They are from the NIH Office of Research on Women's Health, the National Heart, Lung, and Blood Institute, the Eunice Kennedy Shriver National Institute of Child Health and Human Development, and the National Institute on Minority Health and Health Disparities. I also want to thank today the independent panel, who you will meet in a moment, who will be overseeing this workshop and are charged with writing a panel report at the end of the workshop. And I want to thank our workshop speakers. As I noted, we have over 35 over the next 3 days, and to each one of you participating today. So thank you for joining us. I will now cover just a couple of housekeeping slides. Make sure we're all on the same page before we get started. So next slide, Catherine. Okay, so to access the workshop agenda webpage, the link is down there at the bottom. Just a quick note on what you can find there: the final agenda, bios for our independent panel, and bios and abstracts for all of our speakers. A link to the draft systematic evidence review, which is available now through December 2nd, I believe, for public comment. You all received an email about this, everyone who was registered when it first came available for public comment about a month ago. So you have a few more days to review and comment if you haven't already. And then also at this webpage will be the draft panel report when it's available in early 2023, and also the recording from this week's workshop. Next slide, please. Okay, so the Office of Disease Prevention at NIH, the host for this workshop or for the program, recently developed event guidelines that apply to all P2P events and really all events that ODP sponsors. So I want to remind folks of these, and I will read through a couple of these bullets, that we feel in ODP that it is important to uphold the professional and educational purposes of the meeting by respecting the rights, views, privacy, safety, and dignity of all people who are attending, and to exercise professionalism, consideration, and respect in your speech and actions, and to keep all comments that you put in the chat relevant to the event topic. So these guidelines also include our request for all attendees to refrain from engaging in harassing speech or inappropriate behavior, posting comments that are not appropriate, and disrupting the conversation with spam or repetitive posts. All of that, it should be understood, but it is such a good reminder for folks, especially since we expect over 1,000 participants for this full workshop. And a reminder there that if you do see a violation of these guidelines, to just send NIH an email. Next slide, please. Okay, so how to comment, which is really important during a virtual meeting. Use the WebEx chat pod, which is at the right hand of your screen, and submit questions to everyone. Everyone means that everyone on the WebEx will see your question. You can also email questions to NIH at the address there and join the conversation on Twitter. Next slide, please. And if you have technical difficulties, please send a WebEx chat to all panelists. So all panelists refers to the team, the ODP team in the background, who can help with any technical issues, or you could email NIH P2P email box. And we'll be putting those instructions throughout the day in the chat pod in case you forget. Next slide, please. Okay, closed captions. If you need to find them, click on first the 3 buttons on the bottom right of your screen, which will open the multimedia viewer. And then that gives you instructions for finding the closed captions. Next slide, please. WebEx makes it difficult to zoom in on content, so we wanted to call out how to do that. At the very top of your screen, below the box of faces are icons, plus and minus icons, and you can use those to make your WebEx window smaller or larger. Next slide, please. Okay, so opportunities to comment in the future, not just during today's meeting and chat. So like I mentioned, you can review and comment on the draft systematic evidence review prepared by the Minnesota Evidence-Based Practice Center, who we at NIH have been working with for over a year to pull the review together. So we are happy to have everybody review and comment on their draft report. And as I mentioned, review and comment on the independent panel's draft report when it is available in early 2023. Those will both be available on the ODP website listed below. And next slide. Okay, and then a reminder to please complete the post-workshop survey. At the end of each workshop day, a survey link will be posted in the chat, but everyone who registered for the workshop will also receive an email from WebEx with the survey link. Just a quick note that the survey is different for each day, so you'll get 3 different emails from WebEx if you join the 3 days. And we really do encourage you to complete the survey. It only takes 5 to 10 minutes, and the P2P team in ODP really does pour through the comments that we receive in between our workshops, so it's very helpful to us. Next slide. Okay, a reminder to join us for day 2, which starts at 11 a.m. tomorrow. We will cover the patient-centered strategies for care, and then we will also continue covering key question 1 and begin key question 2. I won't read through those now in the interest of time, but we will be explaining the key questions in presentation in just a minute. Registration is required for each workshop day, so if you haven't registered, please go to the link there. I think I have just one more slide. Next slide on day 3. Also starts at 11 a.m. Please join us, and we will finish covering key question 2 and then have a roundtable on cardiovascular risks and interventions, and then a closing keynote speaker. Again, registration is required for each day. Next slide. Great, and now I would like to turn it over to Dr. David Murray, Director of the Office of Disease Prevention at NIH, for a welcome.
Thank you, Kate. My name is David Murray, and I'd like to welcome everyone to the Pathways to Prevention workshop.
Dr. Murray, it seems we've lost your audio.
Lung and Blood Institute, the Eunice Kennedy Shriver National Institute of Child Health and Human Development, and the National
Dr. Murray, we can't hear you right now. We're going to have to.
Dr. Clayton is the Associate Director for Research on Women's Health and Director of the Office of Research on Women's Health at NIH.
Dr. Murray, it does seem like we're having
Research
some
on
audio
diseases,
from him.
disorders, and conditions that affect women. She is also the architect of the NIH policy requiring scientists to condition.
Not sure what's going on with Dr. Murray's audio.
And as co-chair of the NIH Working Group on Women in Biomedical Careers, Dr. Clayton leads NIH's efforts to advance women. Join me in welcoming Dr. Janine Clayton.
Morning, everyone. I'm going to just do a quick audio check here. I know we were having a few issues there.
Janine, we are able to hear you. Thanks.
Okay. All righty. And double checking that I have the opportunity to advance my slides, which I see that I now do. There we go. Great. Good morning, everyone. I am delighted to be here today to talk to you about a topic that is very important to those of us at the NIH Office of Research on Women's Health, or ORWH, and clearly to all of you here. I want to begin by acknowledging all the colleagues and individuals involved in the program today, especially my colleagues at the Office of Disease Prevention. My remarks this morning are entitled Turning the Corner on Postpartum Health, a life course perspective to improve maternal health outcomes. And I'm going to start with this piece of information. I'm sure many of you have seen this the US is the most dangerous place in the developed world to deliver a baby. This image was presented in USA Today in 2018, and I was going to update it with a new image. The data continue to be true, and that's unfortunate, and it's truly a tragedy that this is the case. What's worse is that most of these deaths are preventable. So we're here today to address this critical problem. And if you compare the United States to our peer countries, in this graph, you can see over the last 30 years, our peer countries' rates of maternal mortality, here expressed in deaths per 100,000 live births, are decreasing, while the rates in the United States are increasing. So we're in a situation where women today have a 50% higher likelihood of dying from pregnancy-associated causes than their mothers did. And you can see the total US data there in the red line and a breakdown by race and ethnicity within the United States, underscoring the maternal health disparities that we see in this country with US Black women off the curve here on this graph. If you drill down a little bit deeper, this is a GAO analysis of CDC data where they looked at maternal deaths from all causes over a 4-year period. They were trying to look at specifically the effects of the COVID-19 pandemic. Black populations are in green in the middle bar, white populations in the dark blue, Hispanic populations in the light blue. And you can see a significant increase in overall deaths over this time period. But what I want to draw your attention to in particular, beyond the health disparities, is the fact that the rates of maternal mortality for Hispanic women were lower than those of white women in 2018, but now exceed those of white women and have seen a significant increase year over year from previous years. And in terms of COVID-19 consequences, compared to 2018 and 2019, the COVID-19 pandemic has been determined to be a contributing factor in 25% of all maternal deaths in 2020 and 2021 combined. So clearly another important factor. And we know that the pandemic uncovered some of the prevailing social determinants of health and health disparities that have been ongoing for some time. Along those lines, colleagues at ORWH, we put together a publication entitled Pregnant in the United States in the COVID-19 Pandemic, a collision of crises we cannot ignore, focusing on the fact that maternal mortality rates had been high, the experience for social justice in the United States was changing, and the COVID-19 pandemic was laid on top of that. In addition, ORWH colleagues and others highlighted how important it is to include pregnant, lactating people in COVID-19 clinical trials and the importance of considering pregnant people as a scientifically complex population in these other publications here. Clearly, we need to do more work here in order to be able to generate evidence so that clinicians have evidence from pregnant and lactating people in order to inform individuals so they can make data-driven decisions about their treatment and care. So we are focusing on maternal mortality, but we also recognize that maternal morbidity is critically important. And I know you've seen many of these maps of the United States that show disparities across states, and I'm highlighting a little bit of different information here. In the blue dots are maternal mortality rates, with a larger dot indicating a higher maternal mortality, which is as seen in the lower right southeast states, Alabama, for example, and Louisiana, with high rates of maternal mortality. In the light orange to dark red is maternal morbidity, and you can see a slightly different pattern there, with maternal morbidity rates higher in states like Alaska and even a high rate here in California, with the caveat that ascertainment of maternal morbidity data is variable across states. In order to address maternal mortality, we have to understand morbidity. And the occurrence of maternal morbidity is important not just because of the pregnancy and postpartum experience of that person, but because maternal morbidity can portend poor outcomes for that individual over their life course. We also know that there are variations in the causes of pregnancy-related deaths. Here's CDC information indicating the leading underlying causes at the top, and I want to draw your attention to the fact that mental health conditions, including overdoses, are the underlying cause of death in about 23% of cases. Also want to draw your attention to the fact that causes of death vary by racial group and ethnicity, with cardiac and coronary conditions being the leading underlying cause of pregnancy-related deaths among non-Hispanic Black people, mental health conditions being the leading underlying cause for Hispanic and non-Hispanic white people, and hemorrhage being the leading underlying cause for non-Hispanic Asian people. This data had very few American Indian Alaska Native women, but we know from subsequent and other data analyses that mental health and hemorrhage are important causes in these populations as well. It's also critical to think about when these maternal deaths are occurring in order for us to intervene in an appropriate way. And over half of these deaths occur after the first day of delivery, after the day of delivery, and up to 1 year, 52%. And so this is where we're focusing our efforts today. The opportunity the Maternal Health Pathways to Prevention Conference represents is the ability to bring together stakeholders from many sectors and across many disciplines to work together to solve the maternal health crisis, to turn the corner, as I said, and to make a big difference. Like the international data I showed presented earlier from our peer countries with reduced maternal mortality, we have an opportunity here because CDC data indicate that 80% of maternal deaths are preventable. It's promising to see trends like this with US data across the x-axis here in red and California maternal mortality in deaths per 100,000 live births in teal, which we see a reduction in California's maternal mortality rates. Systematic quality improvement efforts were put in place in the state. They realized they had a problem, put in quality improvement initiatives, used data to inform their decisions, created an integrated system where surveillance data could be used to monitor and inform interventions, and we can see that that can make a difference. However, it's important to note that the Black-white maternal mortality disparities ratio did not go down during this period of time, indicating further need for attention to that disparity. I know you've heard people say that pregnancy is a stress test, and it certainly is. Unfortunately, I feel like today it's a stress test and one that we are failing, our mothers. We think about pregnancy at ORWH in the context of the full life course. On the left there, from early life all the way through the entire life course. And right in the middle are the reproductive years. And we often think of maternal mortality as the tip of the iceberg, depicted here in the reproductive years right in the middle. Beneath that being maternal morbidity, and at the base of that, social determinants of health. The life course perspective is important to consider in light of the fact that depression onsets in adolescence can portend risk for postpartum depression or depression during menopause. We know preeclampsia can predict risks of hypertension even within 3 years of the pregnancy termination based on NHLBI studies and others, and risks for cardiomyopathy postpartum. Gestational diabetes portends a risk for type 2 diabetes subsequently, and we know that cardiovascular disease in women has a differential, type 2 diabetes has a differential impact on risk of cardiovascular disease compared to men. So we need to consider this life course perspective as we think about maternal health in order to have an impact. And I've widened this iceberg here because it really isn't just an iceberg that's relevant to those reproductive years, and those social determinants of health beneath that iceberg at the base are critically important to consider for us to be able to turn the corner on this situation. The ORWH presented this multidimensional framework in our most recent NIH-wide strategic plan for women's health research, where we center women right in the middle and their life course perspective. We realize it's not just about biology, as important as that is. Internal factors like Biologic factors are important, but they must be considered in the context of the life course as well as external factors, women and context in society, whether that's individual factors, interpersonal factors, structural factors, community and societal level factors, which all interact and can have differential effects at different stages of the life course. And it was ORWH's privilege to collaborate with the National Institute of Diabetes, Digestive, and Kidney Diseases several years ago to support an effort entitled Bridging the Chasm Between Pregnancy Health and Health over the Life Course, because we realize so many people do not have a bridge across that chasm when it's sorely needed. This group of stakeholders from a variety of disciplines, including clinicians, practitioners, midwives, social workers, doulas, peer navigators, storytellers, and a variety of other stakeholders came together to look at these issues in a different way. And they discerned these 6 key strategic areas: advancing toward eliminating racism and bias as an important factor for making a change, extending a holistic team-based care approach to postpartum care, implementing a variety of systems that preserve maternal narratives, aligning research with women's lived experiences, and of course, expanding access to care. And NIH institutes and centers have launched a variety of initiatives across the board, too many to list on one slide. I'm just highlighting a few of them here, ranging from the new Mom-to-Be studies and the ancillary studies related to that, looking at heart health, ORWH's understudied, underreported, and underrepresented populations of women, or U3 program, and NIGMS's Idea States program that's recently been expanded to include women's health, as just examples of a few. And recently, NIH has taken on this public health crisis with new eyes and joined forces to tackle it through the IMPROVE initiative. IMPROVE stands for Implementing a Maternal Health and Pregnancy Outcomes Vision for Everyone. The IMPROVE initiative provided supplemental funding in 2 previous fiscal years to expand research addressing underlying causes, the leading causes of maternal death, as well as structural factors, mental health, and other factors in a concerted way. And in FY22 announced new funding opportunities around maternal health research centers of excellence, dissemination and implementation research applied to this area, challenges, data-related advances, as well as community implementation programs, to name a few. Please take a look at the website to learn more about this exciting program. And across HHS, many of our colleagues have all been working hard on this public health challenge. And from CDC's campaign around Hear Her and CMS's campaigns around improving data ascertainment and innovation in dealing with data, and all of our other HHS colleagues, we know that it's critically important for us to coordinate our efforts in order to have the sum be greater than the whole be greater than the sum of the parts, and to really move the needle on this intractable issue. We are today thinking about maternal morbidity and mortality as a braided river, with streams and tributaries that contribute to that river, each person having a unique experience, but coming together into this braided river. And we need to address all of those tributaries. We need to think of maternal health with a whole person perspective, including a life course perspective, and incorporate the interaction of biological, psychosocial, environmental, structural, and other factors, with prevention being our ultimate goal. Prevention research efforts must be holistic and must be multidimensional. Together, we can make a difference. And with that, I want to thank our colleagues and institutes and centers that are collaborating with us on formulating this P2P program, and especially Dr. David Murray, who I will turn this over to, and our colleagues at the Office of Disease Prevention. Dr. Murray?
Thank you, Dr. Clayton. And I hope my audio is better. I understand that there was a problem earlier. Apologies for that.
It's coming through loud and clear, Dr. Murray.
Thank you. Next slide, please. The NIH Office of Disease Prevention has as its mission to improve public health by increasing the scope, quality, dissemination, and impact of prevention research that's supported by NIH. We provide leadership for the development, coordination, implementation of prevention research in collaboration with our colleagues across the campus, all the other NIH institutes and centers. Next slide. We do all of our work based on a strategic plan. We have 7 priorities today. They're listed here on this slide. I'm not going to walk through them, but we cover a wide range of activities, all of it aimed to improve the quality of prevention research sponsored by NIH. Next slide. This Pathways to Prevention workshop addresses our interests under Strategic Priority 2, which is evidence gaps. Our goal is to assess the available scientific evidence through a systematic review of that evidence and through expert speaker presentations to identify research gaps and future needs to better understand how to predict and prevent poor postpartum health outcomes. Next slide. The main components of a P2P workshop are going to be shown in the next series of slides. Everything centers around the independent panel, and I will introduce the members of our panels shortly. Next slide. We start by conducting a portfolio analysis of the work that NIH is doing in the area, the content area. Next slide. That is very much supplemented by an evidence report prepared by our Evidence-Based Practice Center, in this case, the University of Minnesota. Next slide. We have presentations that you'll see over the next 3 days. Next slide. And certainly audience participation we encourage, so please use the chat box to share your thoughts. Next slide. With all of that input, the independent panel then prepares a panel report on research gaps and recommendations for moving the field forward. Next slide. We've been doing these P2P workshops for some years now and are very pleased with the impact that we've had just based on evidence for publications from the evidence reviews, the panel reports. Shown here are some relative citation ratios for some of the P2P workshop publications. All of these are in the top few percent of publications worldwide in the peer-reviewed literature, not just related to NIH work. We've done quite well with a number of these reports. Thank you. Next slide. The key participants are listed here. Certainly the ODP staff has been central in organizing this, but the Institute coordinators play a key role, the content area experts, our friends at ARC and the Evidence-Based Practice Center, certainly the speakers, the participants, and our federal partners. Next slide. The Evidence-Based Practice Center does conduct a systematic review through a contract with ARC and their Evidence-Based Practice Center program. We fund that review through an interagency agreement. The University of Minnesota EPC conducted the review for this workshop, and you're going to hear from Dr. Slaughter-Acey and Dr. Butler later, who will present the findings of the review for this workshop's 2 key questions. The draft evidence report is available for review and public comment through December 4, and the link is shown here. Next slide. The independent panel is critical to the P2P process. We pick panel members because they have no financial or intellectual conflicts of interest. And sometimes people are puzzled, well, why don't you have experts in the content area? We want people who have no conflicts. So we have chosen people who are experts in methods, in clinical practice, and academic research, and public health, a variety of areas that are related to the topic of the day, but they are not experts specifically on the topic for the day. They will produce a report synthesizing findings and detailing recommendations for future research. Next slide. My charge to the panel is shown here. Certainly, I urge you to listen carefully to all the workshop proceedings, to attend all the executive writing sessions, and prepare a draft report shortly after the workshop is finished, to review and incorporate comments that we receive from the public on the draft report as you develop the final version, and then prepare a final report that summarizes the workshop and identifies research gaps and future research priorities. We expect to post the draft report on the ODP website for a 4-week public comment period. We don't know the exact date when it'll be posted, but we will let everyone know when it's available. Next slide. I'm going to ask the panel members to turn on their cameras so that they can acknowledge their introduction as I identify them. The panel chair is Dr. Corinna Davidson, Senior Vice President of Research at Northwell Health. We also have Paula Braveman, Director, Center on Social Disparities in Health, University of California, San Francisco. We have John Epling, Vice Chair of Research and Population Health, Virginia Tech Carilion School of Medicine. We have Pamela Reese, Associate Professor, East Carolina University College of Nursing. We have Mary Beth Terry, Professor, Mailman School of Public Health at Columbia. And we have Stefan Timmermans, Professor, Department of Sociology at the University of California at Los Angeles. So I want to thank the panel members in advance for their hard work, certainly in the 3 days of the workshop and thereafter preparing the report. Next slide. All the panelists will disclose, the panelists have no conflicts of interest. The speakers will disclose any conflicts of interest at the beginning of their presentations. Next slide. Finally, I'll note that the workshop had, I think it's now over 1,000 registrants. We'll have opening presentations from the NIH scientific leads to provide background on the growing maternal health crisis and current research to address it, and why the first year of the postpartum period is so important. We'll have 3 roundtables, and they're identified here. We'll have patient representatives to share personal stories, and we'll have a closing speaker offering perspectives on the importance of increasing research on postpartum health. Next slide. I want to thank certainly our planning group listed here. They've been working for a couple of years to get this workshop ready. Many thanks to our friends at the Agency for Healthcare Research and Quality, the University of Minnesota EPC team, the speakers and panel members, and all of the staff at WestAd, at ODP, and who've worked very hard on putting the entire workshop together. I think that is the final slide. And with that, it is my pleasure to introduce Corinna Davidson, who is the panel chair. She is director of the Institute of Health System Science at the Feinstein Institutes for Medical Research and senior vice president for research at Northwell Health. Dr. Davidson is also past chair of the U.S. Preventive Services Task Force. She served as chair 2021 through 2022 and has been a member of the task force since 2014. Dr. Davidson has authored more than 300 peer-reviewed articles and numerous editorials and book chapters. She formed and is the past chair of the Evidence-Based Behavioral Medicine Committee, a task force charged by 7 national and international societies with improving and implementing evidence-based principles within behavioral medicine. She has won national and international awards for her research, including the Advancing Women in Science and Medicine Award for Excellence, and served as president of many professional societies, including the Academy of Behavioral Medicine Research. It's my very great pleasure to introduce Dr. Corinna Davidson.
Thank you so much, Dr. Murray, and I'm just absolutely delighted to be here with all of you as we start on this important journey to understand what evidence we have to identify risks and interventions to optimize postpartum health. As Dr. Murray mentioned, I'm the chair of the panel. We're very proud to be here with you, learning about the evidence and the evidence gaps through our 3 days. If I could have the next slide. As Dr. Murray mentioned, I don't have any disclosures to report, and I do not represent the views of the USPSTF during the course of this or the panel report. If I could have the next slide. Dr. Murray did introduce you briefly to our panel members. I'm just showing you here their names again so that you know who they are. My main task today is just to describe to you the panel activities that we, the panel members, will be engaging in, and to tell you a little bit about what's about to happen in the workshop. So if I could go to the next slide. Our duties as volunteer panel members are to read the systematic review by the Evidence-Based Practice Center, to consider all of the evidence that is being presented to us, excuse me, by the speakers, as well as the comments and questions from the audience. We will then draft a panel report where we're going to briefly summarize the current scientific literature, address the evidence that was presented by our speakers and by the EPC, and outline recommendations and gaps for future research. We're really going to be focusing on what needs to be prioritized to move this field forward and to contribute meaningfully to the prevention of this public catastrophe. We will post this draft report for comment, and we look forward to having comments and feedback from all of you. And then we will submit the final manuscript to a peer-reviewed journal. And it will be a companion piece of the evidence-based systematic, well, scoping review of the EPC. Next slide. For the workshop process for today, I'm going to tell you a little bit about the structure. We're going to be starting each session with one of the workshop's key questions. The first talk will summarize then the EPC review. Subsequent speakers are going to address the research gaps and present current science and perspectives on risks and interventions in postpartum health. Each speaker will introduce themselves by giving their name, their title, their affiliation, their presentation title, and as Dr. Murray mentioned, their conflicts, if any. And then we will end with a 20-minute discussion period with all speakers from that session. Next slide, please. Just a couple of ground rules before we start. We will have the independent panel members asking their questions first as they're working to understand what needs to be prioritized and included in the panel report. There will be no time limit for addressing questions from the panel members, which may mean that we spend as much as 20 minutes from the panel members. We do want to encourage you, the audience, to ask questions. So if there is time left, we will have those answered by the panelists. However, since we're going to ask you to put your questions in the chat pod, we're delighted to say that if we don't have time to answer your questions, those will be sent to the panel to consider after the workshop. We're going to take a 10-minute break between each session because, as you know, we have a lot of speakers and a lot of information to process. So we will be working hard to ensure that the sessions will start and end on time. I'm going to turn it back to our facilitator, but I would like to end by once more really calling out Office of Disease Prevention for their leadership and their intention on helping all of us to ensure that we contribute to a timely and focused evidence-based report that lays out how we can prevent postpartum morbidity and mortality. And with that, I'll hand it to you, Kate.
Thank you very much, Dr. Davidson. Okay, just a reminder to our audience, if you have questions or comments, which are encouraged, put them in the WebEx chat pod to everyone, direct them to everyone. And if you have technical questions, please direct them to panelists, all panelists. Okay, with that, we will now move into the overview of the workshop, review of the key questions with Drs. Bandatini, Chin, Oladende, Stratton, and Thomas from NIH. And just a reminder to you all and to all of our future speakers that we will leave it to you to introduce yourselves so that we can stay on time. And with that, Dr. Thomas, I'll turn it over to you.
Yeah, thanks, Kate. And I'd like to start with a thank you too. And I want to thank David Murray for this amazing program and the difference it made. I was involved with one about 8 years ago. Kate, I think you were a part of that. And that made a real difference. And I think we can make a difference here. So I'd like to just applaud ODP and also your amazing team. Next slide. And speaking of the amazing team, here they are. We got to know each other very well over the last 2 years. Very talented group, very driven to get this work done. So thanks again. Next slide. Here's our agency leads. We have 3 institutes and the Office of Research on Women's Health leading this. We all come at this problem from slightly different angles, but we have a shared mission and purpose. So I really like that we've tackled this as a group. Next slide. Okay, so we have to focus within a P2P. You can't just take on maternal health and because it's too big for this program. It's a great program, but it can't answer everything. So we had to start to refine, and this took some time, but refine our questions so that they were actionable and also more focused. So we began our journey by focusing on postpartum health. Next slide. Here's a slide that Dr. Clayton shared, and the point here is just that over half the deaths that have to do with maternal mortality deaths are in the postpartum period. So this should be a place where we should focus a lot of our attention. Next slide. At the NIH, we have a system called the Research Conditions Disease Category System. It's a computerized portfolio analysis system where we can find, based on hundreds of categories, how much research is done in various areas. And there is a maternal health category that started in 2017, a pregnancy category at the same time, maternal mortality and morbidity category that started in 2020, but there is no postpartum health category at this point. So this didn't tell us, even though we felt like there needed to be much more research in this space, this data didn't tell us that. But next slide. Fortunately, part of the P2P program is they do a portfolio analysis as part of the process. So we did get these data, and we were able to look at how much attention at the NIH and beyond is paid to the postpartum period. Next slide. This is just showing you how the data was analyzed, what the sources were. It came from Reporter, it came from RCDC, and there was some internal data that they used to develop this analysis. Next slide. So if you look at the number of NIH projects that are relevant to postpartum health, postpartum health doesn't have to be a big part of it, but it has to be in there. There were 531 projects from 2018 to 2021 funded, which is a fairly sizable amount. Next slide. And what was very nice to see, and I won't go into details on this slide, but a lot of stakeholders from across the NIH were helping to fund these projects. And it's just, we're tackling the problem from many different angles. So this was good to see that we're all working together for a common cause here. Next slide. And this is just a circle topic cluster. I don't want to go into the details, but I just want to share this because if you look at postpartum research research that's relevant to postpartum health, it covers the gambit. There's the biological, which we know is an issue, but also the psychological and social aspects, which we also know are issues. So it's good that we are collectively at the NIH covering the landscape. Next slide. However, the story changes somewhat if you look at research that's just focused on postpartum health. It goes from, there were 48 studies funded in 2018, and it did bump up to 94 in 2021, but it's a relatively small number in terms of grants funded. And next slide. And if you look at the dollar amounts, 82 million, about 82 million in 2021. It is making progress. There are more and more studies being funded in this area, but it seems like there's a long way to go, especially, next slide. If you take these data and put them against the RCDC data, you can certainly see something like pregnancy is almost an order of magnitude more funding than the postpartum period, despite the fact that more people die in the postpartum period. Next slide, please. So we do have to focus on postpartum health, but that is still too broad. So part of the structure that the P2P workshop, the systematic evidence review, part of the structure is defining key questions. So, and the key questions need to be actionable and definable and entry points into helping people during pregnancy and after. So the key questions that we developed, next slide, are two. And the first one is at birthing person's entry into prenatal care, what are the risk factors that have the greatest effect on poor postpartum health outcomes? Somebody comes in for treatment, they're in a medical setting. Can that setting be the launching point for better care? This person will have problems, perhaps during pregnancy, during the postpartum period. What can we do now to nip it in the bud? And the second action point is upon exiting the birthing related care setting. So they have the baby, the pregnancy's over, and they leave. And do they go into a chasm where they don't get more continuing care, or do they wait 6 weeks and get one checkup when they're at risk? So we wanted to look at who should clinicians keep a closer eye on and follow the care into the postpartum period. And these questions were made a couple of years ago in the process, but can I have the next slide? It occurs to me that exit sign is probably the wrong thing to use. Next sign. Yeah, it really should be an entrance sign. I mean, after you give a baby, the stress test expands way beyond pregnancy and certainly into the postpartum period. It's there in force. And that should be a place where we pass people off to postpartum care. So, and the other part of this, and we knew that biology matters in terms of health, but with maternal mortality and morbidity, there's a lot of social determinants of health that are also impacting the health of the birthing people. So overlaid on all this research, we want to see how social variables kind of predict when a person's at more risk. Next slide. And this is Dr. Murray's slide. I won't go through it, except this is a convergence of a lot of information. The portfolio analysis, evidence report, presentations by thought leaders, audience participation, it all converges on the panel. And the report, because of this process, and I've seen this firsthand, this report is taken very, very seriously and can have a huge impact. But, and I'm speaking from experience, that's not the end. Next slide. So the report actually can lead to changes in research, priorities, guidelines, policy changes, practice, public awareness can change, and it actually has an impact on the health of people. I believe what we're doing here, all of us is starting to really gather people together, and this is a turning point, I think, for maternal health in general and postpartum health in particular. And that I could see this process being the beginning of where we will be, hopefully in a few years, where we can truly say that the United States is a very safe place to have a baby, because that's the end goal and that's what we're trying to get at here. So with that, I'll stop, and we're going to do a round robin of our subject matter experts from across the NIH. I have the honor to introduce Dr. Juanita Chin. She is with the Eunice Kennedy Shriver National Institute on Child Health and Human Development. So, Juanita.
Thanks, Dave. As Dave said, I'm Juanita Chin. I am a sociologist and demographer at NICHD, where I'm a program officer, and I also co-chair the Maternal Health Coordinating Committee. Next slide, please. During my 5 minutes today, I'll talk about two key infrastructure programs that support scientific discovery in the postpartum health period, as well as some NICHD priority areas for future research and some forward-looking opportunities. Next slide, please. In 2020, NICHD released its strategic plan in which 5 themes were identified. 2 of those 5 themes are particularly salient for today's P2P workshop. The first one is theme 3, setting the foundation for healthy pregnancies and lifelong wellness, which has a goal of improving pregnancy outcomes to maximize the lifelong health of women and their children, as well as theme 5, advancing safe and effective therapeutics and devices for pregnant and lactating women, children, and people with disabilities. And the goal here is to lead efforts to develop, test, and evaluate new and existing therapeutics and devices to find safe and effective solutions that meet the unique needs of pregnant and lactating people, children, and people with intellectual as well as physical disabilities. There are also 2 particularly relevant cross-cutting themes in the NICHD strategic plan. And these cross-cutting themes mean that they are interwoven in all of the activities and the research in which NICHD supports and conducts. And those are health disparities and disease prevention. Next slide, please. The Maternal Fetal Medicine Unit Network, established in 1986, is one of the key programs at NICHD. It currently includes 12 centers and 37 hospitals across the United States, covering approximately 160,000 births per year. The primary objective is to improve obstetric care, pregnancy health, and outcomes for pregnant and postpartum people and their children, their babies, while conducting well-designed, rigorous, multi-center trials in perinatal medicine. As of today, the MFMU has conducted 33 randomized trials and 25 observational studies. Many of the MFMU studies have directed change in both clinical practice and become the new standard of care. The MFMU infrastructure has also led in the education and training of fellows across the United States. Next slide, please. The Population Dynamics Center's Research Infrastructure Program provides funding for cores at already productive centers above and beyond existing institutional resources to actually accelerate the scientific pace of health-related population dynamics research. The scope of these cores includes demographic and social science research on human behavior related to initiating pregnancy, practicing healthy behaviors during pregnancy, and the structural patterning of maternal and infant outcomes. For example, research supported by this program and conducted by the late Dr. Marian McDormand and her colleagues, published in 2021, on population-level patterns of racial disparities in maternal mortality concluded that, quote, the elevated risk of death for Black women across multiple causes of maternal mortality reveals the impact of structural racism on health and healthcare in the United States. Differences in patient-doctor communication, bias, language issues, and shared decision-making and use of evidence-based practices may help to explain these disparities and warrant further investigation, end quote. Next slide, please. In 2019 and 2020, NICHD hosted a series of workshops focused on maternal health. Quite a few themes arose from this multi-directional dialogue with NICHD leadership, researchers, community members, and people with lived experiences. Some of these areas identified are on the screen. Though this list is not exhaustive, it is this type of engagement that helps shape the future directions of our research priorities and our research opportunities. Next slide, please. We're excited about the work currently being done and looking forward to the work we expect to see in the pipeline. Dr. Clayton mentioned this earlier. Part of it is the Maternal Health Research Centers of Excellence. These transdisciplinary innovative research centers focused on developing new and better approaches to understand the biological, the behavioral, the environmental, the sociocultural, and structural factors that affect pregnancy-related and pregnancy-associated morbidity and mortality by building an evidence base for improved equitable care and equitable outcomes. Additionally, there are other opportunities listed here that include notices of special interest in implementation science for maternal health, as well as policy changes and emerging and evolving public health crises on NICHD's populations of interest, and there is also a request for information on stillbirth. Next slide, please. I'd like to acknowledge my NICHD co-leads, Drs. Nahida Shaktora, Roz King, and Monica Longo, as well as thank our leadership and NICHD staff, Drs. Bianchi, Cernich, and Baden, and the NICHD Maternal Health Coordinating Committee. I turn it over to my colleague at NIMHD, Yewande.
Good morning, everyone, or greetings to you all. My name is Yewande Oladende, and I am a program officer and the workshop lead from the National Institute on Minority Health and Health Disparities. I'll be focusing my talk today on NIMHD perspectives on this topic and what we have done so far and future opportunities. Next slide, please. NIMHD was established in 1990 as an office and then transitioned to become an institute in 2010. Our institute is charged with looking at all of NIH to plan, coordinate, review, and evaluate NIH minority health and health disparities research and activities. With that, our mission is to lead scientific research to improve minority health, reduce health disparities, and promote health equity. We envision an America in which all populations will have an equal opportunity to live long, healthy, and productive lives. Next slide, please. This slide shows the NIMHD research framework, which was developed in 2015 to address the cumulative effects of multiple determinants of health. Each cell reflects the determinants or factors that may be relevant for any minority health outcome or health disparity. The framework highlights that conducting research entirely within one cell of the framework, for example, at just the individual or the biological level, which is what many traditional health research may do, often results in an incomplete picture of what is happening. Since we know that health outcomes can span multiple levels and domains of influence, it is important to take that into account and include a life course perspective when studying minority health and health disparities. Next slide, please. Focusing on the impact of social determinants of health on maternal morbidity and mortality, we need to examine the conditions in the places where people live, learn, work, and play, and how that affects a wide range of health risks and outcomes in the postpartum period. Many of the social determinants of health are influenced by structural racism and discrimination that occur across the multiple levels of influence, which intersect across multiple domains of influence. So the red font represents the levels of influence, and the purple the domains of influence. Next slide, please. These are two papers that address the social and structural determinants of health and how they contribute to the inequities that lead to maternal mortality and morbidity. The paper on the left was co-authored by NIMHD staff, and the one on the right by some NIH colleagues and colleagues from the extramural community. Next slide, please. NIMHD put out a request for application focused on addressing maternal morbidity and mortality in May 2020. We had 3 institutes and the Office of the Director sign on. 5 grants were funded by NIMHD and 1 was funded by NHLBI. They included a variety of studies from mixed methods to observational studies, intervention, and secondary data analysis. We know from the research and from what we've heard so far that Black and American Indian and Alaska Native women have higher rates of maternal mortality compared to white women. However, none of the funded studies included Alaska Indian and American Indian and Alaska Native, and also sexual and gender minority populations. Next slide. This slide shows the geographic distribution of the awards from the RFA. Over $2.4 million were awarded across six grants. The purple stars are those that were funded by NIMHD, and the red star is the one grant funded by NHLBI in Pennsylvania. As you can see from this map, there are no awards in the West and the Southwest regions of the country. Next slide, please. The overall goal is to reduce maternal morbidity and mortality by addressing some of the research opportunities listed below. This is by no means an exhaustive list. The first research opportunity identified is the need to examine how positive and protective social determinants of health interacts across multiple levels and domains of influence over the life course, and how these protective factors and resources may buffer against adverse effects of negative social determinants of health. The second research opportunity identified is the need to address mechanistic pathways by which negative social determinants of health create adverse conditions that impact maternal mortality and morbidity. And the third research opportunity is the need to conduct multidisciplinary and multi-level research that addresses the cumulative effects of multiple determinants. Next slide, please. Thank you very much. And with that, I'll pass it over to my colleague, Patricia.
Thank you. And next slide, please. My name is Patricia Bandettini. I'm an adult cardiologist and a medical officer in the heart failure and arrhythmias branch of the National Heart, Lung, and Blood Institute. And I want to echo my thanks to everyone involved, as this has just been a really enriching process for me. Next slide, please. So the NHLBI is deeply committed to supporting work to improve maternal health outcomes. The Institute supports a diverse array of investigator-initiated research that spans the spectrum of basic to translational and clinical work across a broad spectrum of topics, as you can see in that multicolored panel. However, NHLBI has also been the leader in a number of initiatives and has partnered with other institutes and NIH groups to support maternal health programs. Just to name a few, Enrich is a home visit implementation strategy that addresses cardiovascular health disparities in socioeconomically challenged populations. The Maternal Health Community Implementation Project is a partnership with coalitions within the community and research groups working to implement strategies within vulnerable populations. And you've already heard a few times now about the Improve initiative. Additionally, NHLBI supports a number of clinical trials. I've only listed some of the more recent ones at the lower panel here, but these clinical trials, they address practical cardiology questions, looking at things like chronic hypertension in pregnancy, looking at pregnancy risks that lead to later cardiovascular adverse outcomes, looking at peripartum cardiomyopathy in the rebirth trial, and newer therapeutics. Next slide, please. We know from the CDC that cardiovascular conditions contribute to a large chunk of pregnancy-related deaths. And this is throughout the entirety of pregnancy. So pregnancy, delivery, that first week, that first acute week postpartum, through that first year postpartum, which some people term that fourth trimester. And in fact, if you look at that year, you can see that cardiomyopathy by itself contributes to almost 40% of maternal mortality. Next slide, please. And so, while we've done a decent job of advertising to the general public about risks of cardiovascular disease related to high blood pressure and obesity, diabetes, high cholesterol, I think it's become increasingly recognized that there are other factors. And so if you look at things like social determinants, look at ethnic and racial differences, geographic disparities, do you live in an urban area or rural area? We found that these intersections of these variables on top of the cardiovascular risk factors, they all exponentially increase the cardiovascular risk. Next slide, please. Looking just at these two specific studies, the New Mom to Be Heart Health Study is a prospective study that has followed 4,500 women after a first pregnancy. And even in really just a short period of follow-up, so really a mean of 3 years, they found that women with hypertensive disorders of pregnancy or preterm birth had a higher risk of subsequent incident hypertension. And the corollary to that is if you look at the Women's Health Initiative that's been following postmenopausal women for over 2 decades, and in this sub-study of 47,000 women surveyed, they found that women with hypertensive disorders of pregnancy and low birth weight had a greater risk for atherosclerotic cardiovascular disease in menopause. And this is even after you account for your traditional cardiovascular risk factors and other adverse pregnancy outcomes. Next slide, please. So the cardiology community recognizes that this correlation between adverse pregnancy outcomes and the effect on cardiovascular outcomes, and is working to promote information and disseminate this knowledge to the community at large. This is from the American Heart Association, a scientific statement looking at adverse pregnancy outcomes and associations with adverse events. And what you'll see is, on the left-hand side, it's not just hypertension and even gestational diabetes, but things like preterm delivery, placental abruption, miscarriage, small birth weights or large gestational birth weights that are associated with increased atherosclerotic cardiovascular disease. Next slide, please. And so knowing this information, it makes it even more important that we intervene in an earlier time frame. I mean, ideally, we would be intervening pre-pregnancy, but looking at this very practically, at a minimum, this 4th trimester after pregnancy and after the delivery, we can't drop the patient after she delivers her baby. This is our opportunity to screen, to monitor, to intervene on modifiable cardiovascular risk factors. Next slide, please. So the NHLBI recognizes that there is this big picture, that there are things besides cardiovascular biologic risk, social determinants of health, looking at urbanization, poverty, illiteracy, behavioral risk factors. These in combination with your traditional metabolic or biologic risk factors all contribute towards adverse cardiovascular morbidity and mortality. Next slide, please. So that the Institute, with our goal of promoting heart, lung, blood, and sleep health across the lifespan, we recognize that we need to address social determinants of health and these health inequities. We need to optimize clinical and implementation research to improve health and to decrease these disparities. This is all ultimately with the goal of improving maternal health, which we recognize will then translate to reducing cardiovascular morbidity and mortality. Thank you so much. Next slide. I think my colleague, Dr. Pamela Stratton from the Office of Research on Women's Health will now take over.
Welcome, everyone. I share and echo my colleagues' welcome today. We're very excited about the work. And as Dr. Bandittini indicated, I'm Pamela Stratton. I'm an obstetrician gynecologist in the Office of Research on Women's Health. Next slide, please. The ORWH mission is to enhance and expand women's health research, and that includes all women and minority groups, those understudied, underrepresented, and underreported. To do this, we strive to integrate sex and gender into biomedical research to enable women to receive evidence-based care. In our mission to promote career advancement for women in biomedical careers, we strive to enable women in science to reach their full potential. Next slide, please. One of the key principles we've promoted in the last 10 years is the study of sex as a biological variable, as studying sex will strengthen science. Next slide, please. Our meeting over the next 3 days will illustrate that pregnancy is a biological variable that should be considered, collected, characterized, and communicated. And I would like to remind you that we each have been born to a pregnant individual, and thus improving maternal health has a profound impact on the health of everyone and society as a whole. Next slide, please. As you saw in Dr. Clayton's presentation, ORWH considers women's health through a multidimensional framework that considers the biologic perspective or internal factors and women in society through external factors such as gender, race, and individual, interpersonal, community, and societal levels. In that, the postpartum period is especially understudied, underrepresented, and underreported. There is frequently a chasm between pregnancy and postpartum health. To consider health over the life course, we must consider the biologic changes that occur, but also the context and the society for these postpartum individuals. In studying the biological changes, we must use an intersectional lens to enable us to identify those who are ill and triage them to appropriate care. We need to hear their voices as we bridge their care. Next slide, please. An example of this kind of research that is needed is our collaboration with the National Institute of General Medical Sciences through their Institutional Development Award, or IDEA States program. These are the 23 states that have the lowest rates of NIH funding and are generally rural America, where we have a significant maternal health crisis. ORWH has funded administrative supplements for research on women's health in these IDEA states. This work amplifies the work of the Improve initiative that Dr. Clayton mentioned. Next slide, please. Another key initiative of the Office of Research on Women's Health is the Building Interdisciplinary Research Careers in Women's Health, or the BIRCH program. Over 85% of these scholars continue in research, many of them successfully competing for NIH and other funding. 3 of our BIRCH programs are in IDEA states. This research is broad and definitely includes reproductive health and maternal morbidity and mortality. A couple of examples are research that includes health disparities in Black, Indigenous, and people of color pregnant individuals and those who suffer from substance use disorders. We also have had research findings that include postpartum management of hypertension after hospital discharge in an urban population. Next slide, please. Finally, as all of our work has changed in the last couple of years to virtual platforms during this pandemic, I would like to welcome you from the Office of Research on Women's Health and encourage you to enjoy our virtual conference, as together we can make a difference. Next slide, please. And now we turn to our critical questions, and I'd like to thank you.
Thank you to all of our, sorry, this is Kate Winczek. Let me just say a couple points and then I will turn it over to Dr. Bridges. Although, was I interrupting somebody other than Dr. Bridges? Okay, great. Let me just say thank you to our Institute and Center leads for those presentations, the overview of the key questions, the current NIH research and NIH-wide perspectives. As you've already heard this morning, they've really put a lot of work into this workshop over the past 2 years, so we appreciate all of their thinking. We will now hear from our keynote speaker, Dr. Kiara Bridges, on the impact of changes in reproductive justice on maternal health. And let's just do a quick audio check, Dr. Bridges, if you don't mind, see if we can hear you okay. And
can you hear me okay? Yep. Can you hear me and see me? Okay, great. Awesome. So I'll get started. My name is Kiara Bridges. I'm a professor of law at UC Berkeley School of Law. I've been following the chat and it appears that folks would like the links to articles and things like that. I'm going to see if I can send all of my, yes, I just sent all of the references that I will use in my slides. So hopefully you can access them. So the title of my talk today, by the way, I have no conflicts to disclose. The title of my talk today is Maternal Health and the Nation's Failure to Commit Itself to Reproductive Justice. And so I figured it was a good idea to get started with a definition of reproductive justice so that we're all on the same page there. So what exactly is reproductive justice? The term reproductive justice is relatively new. The story is that it was conceived in 1994 by feminists of color who had been attending a conference on reproductive rights. And the legend is that one night during the conference, they met in one of their hotel rooms and commiserated with one another over the fact that the speakers at the conference that they were attending largely failed to realize the socially embedded nature of reproductive rights. That is, the reproductive rights that the speakers had been fighting for and have been arguing were so important. These rights were made meaningless when the possessor of the right was poor, was a person of color, had a disability, was incarcerated, was not straight, was not a citizen or legal immigrant. And so that fateful night in the hotel room, these feminists of color wanted to think of a term that recognized that in order for reproductive rights to be meaningful to people without privilege, the struggles for these rights had to simultaneously challenge racism and poverty and ableism and homophobia and transphobia and xenophobia and so on. And so that night, these women came up with the term reproductive justice, And since then, folks working within the paradigm have come up with a definition of reproductive justice, or RJ, and we define it as, and if you can advance the slide, the complete physical, mental, spiritual, political, economic, and social well-being of people capable of pregnancy that will be achieved when people capable of pregnancy have the economic, social, and political power and resources to make healthy decisions about our bodies, sexuality, and reproduction for ourselves, our families, and our communities in all areas of our lives. And so with that background, I want to shift to a discussion of how the nation's failure to commit itself to reproductive justice has impacted maternal health. And I will begin by saying that there is a strong current of thought that is opposed to thinking about how the nation's failure to commit itself to reproductive justice impacts maternal health. That is, there is a strong current of thought that does not want to take racism and inequality seriously. This current would make people of color wholly responsible for the excess death that they experience in this country. And this current would dismiss racial disparities in maternal mortality and morbidity and racial disparities in health generally as a product of either the bad genes that people of color possess or the quote unquote culture that people of color have. So that's where I would like to start. If you can advance the slide, please. We will start with these commitments not to investigate how the nation's failure to commit itself to reproductive justice impacts maternal health. And afterwards, I want to spend my time discussing where we would look when we are committed to investigating how the nation's failure to commit itself to reproductive justice has impacted maternal health. And we would look at implicit bias, perhaps, but we would certainly look at structural racism. So let's start with genes, shall we? Critical scholars resoundingly reject the idea that genetic differences between the races explain racial disparities in maternal mortality and racial disparities in maternal and just health generally. However, there is always a study popping up somewhere that offers to explain racial disparities in health in genetic terms. For example, a couple of years ago, a group of researchers at Boston University sought to identify the quote unquote role of genetics in Black women's experiences with cancer. Advance the slide, please. And a news story covering this research is sort of reproduced here. And the headline was, BU takes on cancer, racial disparities, genetics can trump income and access to care. And if I just draw your attention down to the bottom of that quotation on the right, a researcher was quoted there as saying, at all ages, mortality from breast cancer is higher for Black women, and it's clear now that it's not due to differences in access, care, or treatments. And so, because differences in access, care, and treatments cannot explain racial disparities in breast cancer mortality rates, these researchers conclude that the answer lies in genetic difference. Now, the problem is that people who claim that genetic differences between races explain health differences between races have never really been able to identify a genetic variation that is specific to a racial group. And the failure to identify race-specific genetic variations is due to the fact that such race-specific genetic variations do not exist. Researchers who propose that genetic differences are causing racial disparities in health usually reach this conclusion after they have controlled for other potential causes of the disparity, like income, like socioeconomic status, like access to health insurance and health services. Now, although these researchers may eliminate many non-genetic causes of any given racial disparity in health outcome, they never identify the genetic cause of the disparity. And their faith that genetic variation between the races exists leads them to presume that such a genetic cause of the disparity exists. And this is exactly what happened with these BU researchers on this slide. They observed that differences in access, care, or treatments do not explain racial disparities in breast cancer mortality. Then they presume that a genetic variation is the culprit behind why breast cancer is deadlier for Black women. And they are going to spend millions of dollars over the course of years looking for this race-specific genetic variation, but they will fail because such a variation is a figment of our collective imaginations. We ought not to claim, we ought to oppose the claim that genetic variations between the races explain racial health disparities because the empirical research simply cannot support it. If you advance the slide, as Dorothy Roberts puts it, it is implausible that one race of people evolved to have a genetic predisposition to heart failure, hypertension, infant mortality, maternal mortality, diabetes, and asthma. There is no evolutionary theory that can explain why African ancestry would be genetically prone to practically every major common illness. But we also ought to oppose the claim that racial health disparities can be explained in terms of genetics because they are a dangerous distraction from those mechanisms that actually explain why people of color are sicker and die earlier than their white counterparts. Think of racial disparities in maternal mortality. When you're like me and you know that these disparities are caused by structural factors like residential segregation and unhealthy housing stock found in the neighborhoods that people of color call home, like the clustering of environmental hazards in segregated neighborhoods of color, like high unemployment rates, like the unavailability of quality health services. When you're like me and you know that these factors are killing Black people, any suggestion that genes are killing Black people just sounds like an excuse. It sounds like an excuse not to address what is really causing the deaths of people of color. So critical scholars reject the idea that genes are causing racial disparities in maternal mortality. We tend to think of this as a claim, as a pretext for a commitment not to investigate the nation's failure to take reproductive justice seriously. Advance to the next slide, please. We also reject the claim that culture explains racial disparities in maternal mortality and health more generally. We similarly conceptualize it as a pretext for commitment not to take our commitment to reproductive justice seriously. Now, it is undeniable that one's behavior affects one's health. There is a greater likelihood that a person who eats healthy foods and works out every day will have better health outcomes than a person who eats fatty, high sodium foods or drinks sugary beverages or smokes cigarettes and doesn't exercise. However, the undeniable truth that unhealthy behaviors lead to unhealthy outcomes is more problematic when unhealthy behaviors are imagined to constitute a culture that explains racial disparities in health. Differently stated, we ought to be wary of arguments that people of color's culture leads them to engage in behaviors that compromise their health. One hears cultural explanations of racial disparities in health kind of frequently. For example, on this slide, there's the argument that the Tuskegee experiment has led to a culture of distrust of physicians and other healthcare providers among Black Americans. This culture is thought to have damaging health consequences as it leads Black Americans to refuse to seek medical care when they ought to do so, or refuse a safe and effective vaccine for a highly contagious and lethal virus. Another example is the argument that the foods that comprise the cultural repertoire of soul food, foods that Black Americans are believed to eat because it is a part of our culture, these are the sugary or high fat, high sodium foods that lead to obesity, hypertension, and diabetes. It is myopic to argue that when people of color engage in unhealthy behaviors, it is because their culture made them do it. It is myopic because the reality is that oftentimes the lives of people of color have been constrained in ways that make unhealthy behaviors the only option. In other words, the health behaviors of people of color are not cultural. If people of color do not go to the doctor as often as they should, it may be because they are uninsured or there are no health providers accessible to them. We don't have to blame the Tuskegee experiment for Black folks' distrust of healthcare providers. It might be an incident that happened to them just the other day, right? We don't need to look to the 1920s and 1970s. We might be needing to look at 2022. If people of color drink alcohol to excess, it may be because they are coping with poverty. If people of color eat foods that are high in fat and salt and sugar, it may be due to these foods being the only affordable option in their neighborhoods. You guys, it's called the dollar menu. You can get a full-blown meal for $5. And you can advance the slide, it'll show you what it looks like. $5 meals look like this. These are the high fat, high sodium, high sugar foods that are dangerous to health. See how far $5 gets you at Whole Foods. Belgian Endive was just $7.99 per pound the other day. And of course, there are the droves of studies that show that behavior differences cannot explain racial disparities in health. If you can advance the slide. One scholar summarizes the literature succinctly. As observed 10 years ago, health behaviors can be potent contributors to disease risk. There is little evidence, however, that alone or in combination, health behaviors can explain racial and ethnic health disparities. So identifying genes and culture as the causes of racial disparities in maternal mortality represents a commitment not to think about how the nation's failure to commit itself to reproductive justice has impacted maternal health. But where should we look when we are committed to thinking about the relationship between reproductive justice and poor maternal health outcomes? The reality is that we should look at a lot of places. Unfortunately, most of the attention has landed on one place, on providers. Not on providers as bigots or as bad actors acting badly, but rather it has landed on providers as possessors of implicit biases that cause them to offer inferior health care to their patients of color. Indeed, the most popular theory of racism and inequality in healthcare today is the fact of implicit biases. However, there are significant limitations to this theory. And first, I want to describe the literature on implicit bias, and then I want to discuss the weaknesses. In 2005, the Institute of Medicine, or IOM, which has now been renamed the Health and Medicine Division, the IOM released a report documenting that people of color receive lower quality health care than white people, even when one controls for insurance status, income, age, and severity of conditions. And by lower quality healthcare, the IOM meant the concrete inferior care that physicians give their Black patients. The IOM reported that racial minorities are less likely than white people to be given appropriate cardiac care, to receive kidney dialysis or transplants, and to receive the best treatments for stroke, cancer, or AIDS. And the IOM concluded by describing an uncomfortable reality. Please advance the slide. Some people in the United States are more likely to die from cancer, heart disease, and diabetes simply because of their race or ethnicity, and not just because they lack access to health care. Many studies have buttressed the IOM's findings by documenting that providers are less likely to prescribe and deliver effective treatments to people of color when compared to their white counterparts, even after controlling for all of the characteristics that we think ought to explain the differences in care. In light of these studies, observers have argued that if Black people are dying during pregnancy, childbirth, or shortly thereafter at higher rates than their white counterparts, this may be because physicians have racial biases, and their biases may cause them to give their patients of color inferior health care, and in so doing, contribute to higher rates of maternal mortality among Black women. Now, most researchers thinking about the ways in which providers have provider bias might contribute to racial disparities in health have looked to providers' implicit biases. And the idea is that providers have views about racial minorities of which they are not consciously aware, views that lead them to make unintentional and ultimately harmful judgments about the care that they give people of color. Advance the slide, please. Many of you are familiar with the implicit association test, a test that purports to measure test takers' implicit biases by asking them to link images of Black and white faces with pleasant and unpleasant words under intense time constraints. When physicians are given the IAT, they tend to associate white faces and pleasant words more easily than Black faces and pleasant words. In fact, research shows that these anti-Black, pro-white implicit biases are as prevalent among providers as they are among the general population. Essentially, there's nothing about medical school or residency programs that would cleanse individuals of the biases that people generally have in this country. And so further, there is research that purports to show that providers' implicit biases impact the healthcare that they give. Now, again, when medical schools and residency programs attempt to address racism in healthcare, this is the focus that they tend to have. The focus is on implicit bias. And programs tend to educate students or residents about implicit biases. Some of them even give their students an IAT so that students know that they have implicit biases and the extent of them. And then programs tell students and residents to go out there and be mindful about how their documented implicit biases may influence the healthcare that they give. Now, all of that is laudable, but my issue is when we explain racial disparities in maternal mortality and morbidity totally in terms of implicit biases, we miss something. Implicit biases have to be put in conversation with institutional and structural racism. And now I want to turn to a discussion of the analytical limitations of the field of implicit bias. And then I want to ask the question, what do we see when we put implicit biases in conversation with institutional and structural racism? So first, the field of implicit bias is limited on its own terms. The field is focused on the individual and the prejudices and aversions that he or she or they may or may not possess. Note how that field is a piece with traditional understandings of racism, understandings that posit that racism is what happens when racist individuals think racist thoughts and then do racist things. Progressive theorists of race and racial inequality have fought tooth and nail to challenge that narrow formulation of racism. We posit instead that in the post-civil rights era, if you can advance the slide, racism is better defined as what happens when institutions and structures operate in a race-neutral manner that nevertheless perpetuates historical racial disadvantage and produces new forms of racial disenfranchisement. Nevertheless, implicit bias remains squarely in an individual-centered paradigm, and this is a framework that causes us to think of racism as a private concern, thus mitigating any responsibility for the state and society more generally for the eradication of racism and racial inequality. And so we might be dissatisfied with implicit bias research being the only thing that we're interested in because it might commit the error that non-critical thinkers of race make. It might focus on individualist racism while ignoring institutional and structural racism. We might be focused on providers' implicit biases while ignoring the two-tiered healthcare system within which they operate. We might be focused on figuring out whether providers can match a white face to a positive word faster than they can match a Black face to that same word while ignoring the social determinants of health. Further, there is an argument to be made that the problem is not entirely that individuals have implicit biases, it's that the problem is that we have constructed a society in which people of color are at the bottom of most measures of social well-being. People of color are more indigent than white people. They are incarcerated more than white people. They are unemployed more than white people. They are detained in immigrant detention camps more than white people. They rely on the social safety net more than white people. They die violent deaths more than white people. They are sicker than white people. They die earlier than white people. And it is doubtful that implicit biases alone can explain these disturbing inequalities. More likely, the reverse is true. These inequalities explain implicit biases. Please advance the slide. It is for this reason that progressive theorists of race have argued that the best approach to dealing with implicit bias is through a sustained process of cultural change that results in the elimination of the socially disfavored status of a subordinated group. If people of color are not invariably located on the bottom of social hierarchies, providers likely will not have negative implicit biases about them. But perhaps even more importantly, the field of implicit bias has to be put in conversation with structural racism. If we put the field of implicit bias into conversation with structural racism, one of the first things that we would notice is that individuals with implicit biases, as well as individuals without implicit biases, are practicing medicine within a two-tiered healthcare system. This is a system that allows for the privately insured to access healthcare that is simply better than the publicly insured, not to mention the uninsured. We have to acknowledge the structures within which individuals with and without implicit biases operate. My first book is called Reproducing Race, an ethnography of pregnancy as a site of racialization. And in that book, I conducted 18 months of ethnographic fieldwork research in a public hospital in New York in an obstetrics clinic. And I'm not telling you anything new here. When you're in a public hospital, an underfunded, sort of overburdened institution, time constraints is like the theme of the day. Providers have very little time to see their patients. Sometimes patients, 2 or 3 patients are booked into a 15-minute slot. It's just kind of like the nature of the game. And notice how time constraints being the theme of the day in public institutions, those are the precise conditions under which we should expect people to act on implicit biases. If we have time to reflect, if we have time to investigate our assumptions and investigate the choices that we're making, we wouldn't act on any implicit biases that we have. However, when we are under intense time constraints, again, acting on our implicit bias is an expectation. So again, we have to investigate the structures under which people are operating, and those structures will go a long way towards explaining why folks have implicit biases, who have implicit biases, will act on them. And finally, I want to turn our attention now to social determinants of health. For the uninitiated, I doubt the uninitiated are on this call, but social determinants of health are the conditions under which people live that affect their health states. You can advance the slide. Critical scholars are committed to the idea that these structural factors, the availability of healthcare, quality schools and education, hazardous jobs, safe and secure housing, nonviolent, unpolluted cities and communities, these structural factors go a long way towards explaining the poorer health that people of color have. There are studies upon studies upon studies documenting that the environments in which racial minorities live, work, play, and age are all likely to compromise their health. For example, we ought to consider the role that environmental injustice has played in producing the racial disparities in maternal mortality and morbidity that are so well known. It is incontrovertible that the communities in which poor people and people of color live are more polluted than the communities that their affluent and white counterparts call home. The range of environmental harms that disproportionately impact marginalized people is truly vast, almost comprehensive. Studies have documented that poor people and people of color are more frequently exposed to lead in their housing and in their neighborhoods. Studies have demonstrated that low-income people and people of color are much more likely to live in neighborhoods with poor air quality. The neighborhoods that people of color and poor people call home are more likely to be proximate to uses that pollute the land, hazardous waste sites, landfills, incinerators, polluting factories, and brownfields. The water that people of color and poor people drink, wash their food, clean their clothes in, and use for baths and showers is more likely to be tainted with harmful chemicals. Moreover, low-income people and people of color are more likely to be exposed to toxic chemicals in the course of performing their jobs. To be precise, the jobs that people of color more frequently perform, farm worker, nail technician, sanitation worker, right? All of these jobs require people of color to come into contact with harmful substances. Marginalized people's health they're exposed to harmful pollutants in numerous areas of their lives. And if you can advance the slide, environmental justice lawyer Luke Cole explains, if you can advance the slide, poor people are more likely than others to have multiple exposures to environmental dangers, facing more severe hazards on the job, in the home, in the air they breathe, in the water they drink, and in the food they eat. Indeed, it may be more accurate to say that poor people and people of color find environmental dangers impossible to avoid. I mean, many people assume that the excessive exposure to environmental harms that people of color face is solely a function of the disproportionate poverty that they bear. The assumption might be that people of color are more likely than their white counterparts to live in polluted communities because people of color are more likely than white people to be poor. However, this is not true. Even when one controls for class, people of color are more likely to be exposed to environmental harms in their communities. And if you can advance the slide, you'll see that Mike Ewell, environmental justice lawyer, has written, if one wants to compare a middle-class community of color to a low-income white community and look at which community is more likely to have a hazardous waste facility sited there, the middle-class community of color would have a greater chance of being targeted for such a facility. And Robert Bullard, who we call the father of the environmental justice framework, has written that Black households with incomes of $50,000 to $60,000 live in neighborhoods that on average have more polluted air than neighborhoods of white households with incomes less than $10,000. So we ought to be curious about this when we are thinking about ways to eliminate racial disparities in maternal mortality and to improve maternal outcomes in this country. We ought to be thinking about the social determinants of health, as well as the clinical encounter when thinking about racial disparities and maternal mortality. And I want to note that there's nothing inevitable about the fact that people of color inhabit the most polluted environments. There's nothing inevitable about the fact that people of color inhabit these environments while also lacking the means, like health insurance, to protect their health. You can advance the slide. The World Health Organization's position on this issue is compelling. It is written that the unequal distribution of health damaging experiences is not in any sense a natural phenomenon, but is the result of a toxic combination of poor social policies and programs, unfair economic arrangements, and bad politics. So again, implicit biases harbored by medical providers may be impacting the healthcare that they give patients of color, but the society in which patients of color are living, the society is doing a lot of the heavy lifting when it comes to shortening and reducing the quality of their lives. Thank you. We can advance the slide, and that's it. I think we have time for questions. I'll leave it to you guys.
Yeah, we do. Thank you so much, Dr. Bridges. That was really an impactful presentation. And if you can see from the chat, we have a lot to discuss. We have about 10 minutes, so yeah, it's wonderful. So I will turn it over to our panel chair, Dr. Corinna Davidson, to lead the discussion.
Thank you so much, Dr. Bridges. The comments are just pouring in, as well as some of the questions. I think we're going to start by opening it up to panel members to see if they've got any specific questions or comments that they would like to have addressed. I'll just give you a moment and ask you to turn on your video screen if you do want to ask a question. I'm seeing lots of congratulations and thanks and clapping. I'll just give one more minute to the panel members in case one of them has a question. I will start then, Dr. Bridges, by just asking, in this in-depth analysis that you have conducted and the qualitative observations that you had, did you ever see any interventions or changes that you would recommend be considered or followed up on?
Absolutely. I think one of the most impactful changes that I have seen in my time sort of researching this question is the extension of Medicaid from beyond simply 8 weeks postpartum to 12 months postpartum. So when I was conducting research in the obstetrics clinic in New York, the Medicaid program there, 8 weeks postpartum, all health insurance ended. And so people were kind of left without access to healthcare. Recently, California passed a very temporary measure. It's supposed to last only a year or a couple of years, maybe 5 years, in which Medicaid is extended for 12 months postpartum. And as the speakers from earlier this morning have noted, many of the maternal deaths happen several weeks even after giving birth. And so it's important for recently postpartum folks to have access to healthcare so that clinicians can keep an eye on them so that they can report any concerning symptoms, anything to their providers so that we can keep them alive, right? So I think one of the most important interventions that I've seen is the extension of Medicaid to a year postpartum.
Okay, Great.
I'll also note, though, that when I was conducting research in New York, I think that surveillance is so key. I think that keeping track of data, keeping track of what's happening in the institution is so key. You can't intervene in processes if you don't know what's happening in the institution. And so if you have, for example, higher rates of C-sections among Black people, for example, or Black people are not given the ability to attempt VBAC, while their white counterparts might be given the opportunity to attempt a VBAC. You won't know that you need to intervene in these disparities if you're not keeping track of the data. So surveillance is incredibly important, data keeping, so that you know what exactly is happening inside of the institution. And this is going to vary from institution to institution, right? So this is really a charge to the heads of OBGYN departments, the heads of ambulatory clinics, the heads to begin tracking that data if they're not already doing so.
Wonderful. We have 2 questions from the audience, which again, we'll be sending you the transcript of the chat. There are many conversations going on in there, so it's quite inspiring to see how much you've energized this group. The first question is, has there been any work on how to counteract or mitigate implicit biases other than raising awareness? It is important at a systemic societal level that those who control access to quality care or provide care not only learn about implicit bias, but actively train to counteract systemic and structural racism.
Right, absolutely. I think sometimes my presentation is misunderstood as saying that we ought not to think about implicit bias at all. But that is not at all how my presentation should be received. Instead, I am saying that the implicit bias cannot be the entire universe of what we think about when we think about racial disparities in anything, racial disparities in maternal mortality, racial disparities in health generally, racial disparities in incarceration rates. Like, implicit bias is not doing all of the work. And so we have to, so absolutely, actually raising awareness about implicit bias actually goes a long way towards counteracting or preventing people from acting on their implicit biases. When people know they have implicit biases, and again, this is part of the tracking, the data tracking, the surveillance that I was talking about. When institutions and individuals inside of institutions, 1, know that they have implicit biases, and then 2, those implicit biases may be impacting the care that they give, they're less likely to act on them, and so their disparities are reduced. And we've seen this in many different contexts, policing, juries, judges, so on and so forth. Of course, I'm very familiar with the legal context in which we see this. But that can't be everything that we do. As I was arguing in my presentation, the most effective way of dealing with implicit bias is to make implicit biases not make sense, right? There's a reality testing that happens, right, where people might assume criminality from Black males, but that assumption is reality tested, and we've made it make sense. Because if we look at our racial disparities in incarceration, Black men are overrepresented in the criminal legal system. And so if we're really interested in lasting change, we would be changing the conditions under which people are developing these implicit biases in the first place. If their implicit bias didn't make sense, then they wouldn't have it. And so I want to observe that that's hard work, right? That's the hardest work to do, right? To reject the carceral logics that have kind of organized society up until this very point, to rethink, alternatives to police and prisons and jails, and instead think of ways in which we might deal with, for example, harm when folks cause harm to other folks without turning to the institutions that we have always relied on. That's really hard work. It's much easier to give police, it's much easier to give physicians, it's much easier to give researchers the implicit bias test and tell them to be mindful about their documented implicit bias. And so I think that we have to be interested in the hard work as well as the discrete, more modest measures that we can do, which is, making sure that people are aware of implicit biases and tracking, disparities in institutions. We ought to do that in addition to the hard work. And while I have this audience in front of me, I want to note that the expertise of those and on this call today, I think that you can leverage your expertise in ways that, for example, I can't. So I saw one of the comments earlier in the chat that said that my presentation is not science, right? I have a JD, I have a PhD in anthropology, and there are many who will dismiss my expertise because it is not, the PhD is not in biology or in some other sort of biological science. I think that it is important for the folks on this call to leverage your expertise by using your credentials to partner with folks who have these larger perspectives on this issue, so that when I say that implicit bias is not the entire universe of things we ought to be concerned about, when a person with an MD and a PhD in biology makes that same claim in conjunction with me, then that is received as science as opposed to something ancillary to science.
I think an incredibly important point. Given your insightful observational studies that you were reporting on so carefully, we have another question from the audience. If you're aware of similar research about women of color that give birth in either the Netherlands or in England, that is, how much is the context of the US structural racism at play here as opposed to more universal or global racism?
Right, absolutely. So, we should, and as one would expect, right, in countries that have universal health care, in countries that ensure that people have health care at all times and not simply when they become pregnant, they have better health outcomes, right? And so we know that the US is the only industrialized nation whose racial disparity, or rather maternal mortality rates are increasing. We also know about the dramatic racial disparities in maternal mortality rates that are so well documented. However, even in the UK, even in the Netherlands, racial disparities in maternal mortality and morbidity persist. Of course, they're smaller, and of course, the overall rates are lower, but those racial disparities persist. And so what that suggests to me is that this is multifactorial, right? So of course, our two-tiered healthcare system is contributing to racial disparities in health, absolutely. The fact that many folks don't have access to healthcare until they become pregnant, absolutely, that is contributing to racial disparities in health. The fact that people of color in this country disproportionately bear the burdens of poverty, that is contributing to racial disparities in health. However, there are other things that are contributing to racial disparities in maternal mortality. And the fact of anti-Blackness must contribute to racial and the fact of anti-Blackness, both in the US as well as in the UK, as well as in the Netherlands, is contributing to the fact that Black people just find it harder to survive pregnancy, childbirth, and the postpartum period, which is to say, I would love to see research into the physiological effects of racism. I would love to see us identify the biological mechanisms that make it, that are produced or that translate anti-Black racism or xenophobia or transphobia. I would love to see research into investigating how these forces that we know exist, how those manifest on a biological level and are contributing to the fact that it's harder for marginalized people in this country to simply survive, to live, right? As I mentioned in my presentation, money, so much money is given to looking for that race-specific genetic variation. If you want to get funded for some research, say that you're looking for race-specific genetic variation that explains anything, asthma, hypertension, COVID-19 mortality, right? Just say that you're looking for the race-specific genetic variation, and you are much more likely to get funding for your research than if you say that you're interested in the social determinants of health. And certainly if you say that you're interested in investigating how anti-Blackness, the biological mechanisms by which anti-Blackness kills people, right? So I would be interested in that. This is something that we can do internationally. If it is true that Black folks find it hard to live in the US as they find it hard to live in the UK, as they find it hard to live in the Netherlands, then this is something that we might have collaborations with people from other institutions to see how those things work, so that when I make this claim, I'm accused of not being science.
Thank you. I think you actually addressed that very concisely. We have another question from the audience. From your extensive experience, have you seen successful models using community engagement to get patients and community stakeholders involved with driving some of these larger structural interventions that you're discussing?
Yes, I think that community organizations are so vital. So I can talk specifically about one intervention that we know works, and that I see a lot in the Bay Area and in California, and that is doula training. Doulas who are trained from member or community organizations who train people in the community to be doulas. And so, empirical research exists that shows that folks who are cared for by doulas, they have better outcomes, they have lower rates of C-section, they have lower rates of complications postpartum. And so we know that doulas work. There's a concern, of course, that part of the reason that doulas are effective is that they're an advocate in, labor and delivery and pregnancy and postpartum. The idea is that if the doulas come from the community from which the birthing person comes, then they're even more effective at being an advocate. They're more effective at knowing the concerns of the birthing person. They're even more effective at navigating the institutions that the birthing person has to navigate. So I love seeing these organizations train doulas in order to empower folks from the community when they are giving birth in the institutions that are located inside of the communities.
Okay, terrific. We're coming to the end of our question period, and then we'll have 30 minutes for lunch. Dr. Bridges, I'd like to give you the final word. If you were to speak to the panel members about the call for action you would like us to draw from your talk, what would that be?
Oh, wow. That's a tough one. I guess my call for action, of course, is to be skeptical of culture as an explanation for differences. I think we have to be skeptical, of course, of the unending, never-ending search for that race-specific genetic variation that's just killing people of color. I think that we should just be mindful of structures. And I would really, like I said, I would really be interested in seeing research in which we are identifying how the biological mechanisms that connect the structures in which people are existing and the outcomes that marginalized people are having.
Okay, terrific. Well, thank you for spending your time with us. I think, as you will see from the transcript of the chat, everyone has been very moved by the testimonials and the observations that you've had with such an acute eye. With that, we'd love to have everyone back at 1:30 p.m. Eastern time for lunch. So there is approximately 30 minutes to get off camera. I'll turn it back to you, Kate, in case there's any final words before we go.
Yep. Thank you, Dr. Davidson. The only thing I want to say is just stay connected to WebEx. You can put yourself on mute, turn your video off, but please stay connected, and we'll start promptly at 1:30. Thank you. Shot. So this afternoon, we will have a roundtable on behavioral health concerns impacting postpartum health. And the roundtable will be moderated by Dr. Mishka Turplin. We will have, so the speakers in the beginning of the roundtable will each do a couple of minutes of slides and ask the speakers as usual to turn your cameras on when you're doing that. And then the presentations will be followed by a discussion session led by Dr. Turplin. At that point, we ask all the speakers to turn your slides back on. Or to turn your cameras back on. We also want to mention that we have a graphic artist joining us for this roundtable session and also for the roundtable sessions on day 2 and 3 of the workshop, who will be kind of graphically illustrating for us the discussion in real time as it's happening. So we're really excited to have this addition to a P2P workshop for the first time, and we think it will be really interesting for the audience. Just a reminder, if you have questions during the roundtable or even after for the speakers, feel free to put them in the chat, send them to everyone. And if you have any technical issues, please send your questions to all panelists. And I think with that, we will get started. Dr. Turplin, are you ready?
Yes, thank you. And thank you everyone for joining. I'm really looking forward to this panel. I'm going to ask each of the presenters to briefly introduce themselves, and then I'll come back on camera at the end with some questions. I'll be monitoring the chat and look forward to the conversation. So I think it's first up is Dr. Yonkers.
Good afternoon, everybody. My name is Kimberly Yonkers, and I'm the Katz Family Chair and Departmental Chair of Psychiatry at the UMass Chan School of Medicine. And I'm going to be speaking this afternoon a bit about the risk of perinatal mood and anxiety disorders. So we're shifting gears here, a little bit at least. Let me begin. Is somebody advancing slides?
Yes, I'll do that for you.
Okay, if you could please. Okay, so we'll just begin with my disclosure statement. And I have nothing to disclose. Next slide, please. And next slide, please. So the previous speakers have alluded to pregnancy as a stress test, but pregnancy is also a stress test for the brain. And that's what I'm going to be speaking about just very, very briefly. Next slide, please. And in this particular instance, I'm speaking to you both as a researcher and as a clinician. And earlier in one of the presentations, people talked about the need to address longitudinal risk factors or take a life course strategy when looking at data. And this slide really illustrates, I think, one of the things that we confront when we're trying to plan for prevention strategies and when we're trying to treat patients, which is early in life or even later in life, people can be exposed to factors that really damage self-esteem. And that's what you see here. So interpersonal violence, stress, racism, microaggressions, childhood abuse, chronic verbal abuse, neglect. And these assaults to a person's self-esteem increase the risk of depression. Now, there are ways to mitigate this, but I think we have to take into consideration the very profound impact. And we've been talking a lot about racial stress and various components of stress and people's environment that can have an impact on a person. And when you think about the individual and the brain, you know, one of the pathways to that may be self-esteem. Next slide, please. But of course, there are other risk factors that are associated with both depression and anxiety. Poor social skills, which again may be environmentally related, certainly related to upbringing. Poor social support, that's a lot of what we were talking about earlier. Interpersonal isolation. Genetics, I know that genetics is not totally the reason for some of the things that we see or some of the outcomes we see, but I think we have to also take into consideration that they could be a component of biological vulnerability, for example, to a mood or an anxiety disorder. Poverty, chronic stress, substance use disorders really interdigitate with mood and anxiety disorders very strongly, as well as chronic and severe general medical or obstetric conditions. Next slide, please. Now, the other major factor that we've been talking about all morning and that we have to continue to consider as we think of our research agendas are the intersectionality of race, sex, etc. So, you know, one might say that, for example, women have historically been underfoot and have been subjected to a great deal of bias. Well, now we're also talking about race and ethnicity, which is a major factor, contributes to bias and stress. So individuals who get pregnant, they're not always women or self-identify as women, but they often are. It's a two-hit factor, right? So they have to contend with both the gender component as well as the sex, race, or the race and ethnicity, which can increase the risk for depressive symptoms. And then there are also other factors, and I'm taking this from a paper that I did several decades ago where we looked at the risk of depression, and we found that social determinants of health, the burden, the personal history of mental health issues, and racism contributed to the onset of depression. Next slide, please. Fast forward, and the situation is not substantially different. These data relate to individuals, pregnant individuals who have been exposed to interpersonal violence during pregnancy. And I think everybody would agree that exposure to interpersonal violence increases the risk of an anxiety disorder or depressive disorder. You know, for example, PTSD is an anxiety disorder or panic disorder. But when you tease out the intersectionality of it, when you start to look at the components of it, the magnitude from this slide is pretty obvious. There's risk for everybody, but there's more risk for certain groups. And it's only by diving into the data and to looking at these individual components are we going to begin to understand what's going on and what some of the mechanisms are. Next slide, please. And that's also what's shown here, which is a study of acculturation stress, in this particular instance, gravidas of Mexican descent. And so it's not just the stress, and you see stress here has a major component. In this case, the dependent variable is a depression measure. So stress increases the likelihood of scoring higher on this depression measure, but also the pressure to feel like you have to take on the mantle of your home country and what that does to you also increases the risk of depression during the perinatal period. Next slide, please. Now, this could be one model as we think about depression and anxiety and the prevention of depression and anxiety. You know, certainly individuals who are pregnant have a lot of biological changes. What can we do on the biological domain to protect individuals, to help them? Perhaps, you know, one of the most easy, I think, things to think about are things like antidepressants or anti-anxiety medications. But there are also non-biological changes or non-biological interventions we can consider. Acceptance and mindfulness, which is sort of like yoga, but now we have therapies that actually codify it and are very effective for treatment. Education, emotional regulation, problem solving. These are just some tools that we can help our patients with by providing treatment and education, behavioral activation, communication skills. These can help stabilize emotions for people who are at risk for depression or anxiety and stave off the likelihood that they'll develop something that's worse or a full-blown disorder. It also can allow them to better engage with supports outside of their own family or within their own family. And we know that these factors lead to an increase in resilience. Next slide. Now, just to see this at work, this is actually from an IOM report, I believe, no, Surgeon General's report, looking at possible interventions to decrease the risk of perinatal depression. And there are 2 evidence-based treatments, or if you will, interventions that can help individuals who are at risk for developing a depressive disorder during pregnancy, and they include cognitive behavioral therapy and interpersonal therapy. I do want to note that there are also some data to suggest that IPT, which is interpersonal therapy in this ROSE format, may be more effective for individuals who come from challenged backgrounds and individuals of color. Next slide, please. But one of the things that we have not investigated as successfully are some of the biological mechanisms of risk and prevention for depression and anxiety. So a lot of the work, I think, has focused on psychological processes that I just reviewed, but we need to understand the biology and the biology in the context of the psychology and vice versa. So for example, the pregnancy is a stress test. It's a stress test for the brain. We know that corticotropin releasing hormone levels change across pregnancy. They are the biological clock. What does that do to the brain and to risk of mood and anxiety disorders, or just feelings of depression or anxiety? The serotonin transporter, which is a monoamine transporter, is affected by estrogen and progesterone. How does that increase or decrease risk during the perinatal period? COMT and MAO receptors, other monoamine receptors, similar situation. How are they affected by endogenous hormones? And sterile inflammation. Inflammation is actually a model for depression, and we know that the immune system is very involved in pregnancy, and it has to prepare basically for having a fetus, which is not the same as mom. So inflammation is very important. And how does that relate to the risk of a depressive or anxiety disorder? Next slide, please. So just in terms of some of the gaps that I've noticed in the literature, the data on risk factors among various race and ethnicity groups are really inadequate. And we've talked a little bit about that today, and I know we're going to talk more about that. While we have prevention interventions, they really only help about 1/3 of individuals who are at risk. And it's not clear if they require some sort of modification to get at some of the more highly risked populations. Research has really not established biological risk factors, and really that's a standout, and I noticed it in the report as well. We have insufficient data on effective somatic interventions, whether it's pharmacological or other. Next slide, please. So in terms of recommendations, I hope that some of the things that will come out of this particular conference are the consideration of projects that have sufficient power and appropriate measures to characterize many of the multiple risk factors among the different race and ethnicity groups. And we can appreciate that you need large sample sizes in order to look at these factors. Projects that investigate biological risk factors that may or may not include genetic risk, and ideally alongside some of the psychological risk factors. Consider combining and comparing genetic risks to other risk indicators, and consider exploration of somatic interventions for risk, even such banal things as continuing medication in pregnancy. And with that, I'll stop. Thank you very much.
So this is Kate Winsack. I'll step in for Dr. Turpelin and say we can take our next speaker now. And I think, Catherine, you can just go to the next slide for Emily Miller. Thank you, Emily. Do we have Dr. Miller's audio? Catherine, can you tell?
It looks like she might have had some network issues. We lost her video after it froze. maybe we'll wait another second to see if.
Let's wait. Yeah, let's wait just a second, and then we can go on to Dr. Acord if we need to, and circle back to Dr. Miller.
So Dr. Miller is unmuted on the WebEx platform. She might be double muted on her device.
Without her, I feel like her video would be coming through. It froze right before she started talking, or would have started talking. I'm guessing. Looks like she's rejoining and might have had a WebEx crash on her end. I see her twice on the participants list now. Give her a moment to get her audio connected. Emily, are you able to hear us?
Why don't, in the interest of time, why don't we move on to Dr. Acord, and we just tested her audio, so we think she's okay, and then we can circle back to Dr. Miller after. So Dr. Acord, if that is okay with you, and then Catherine, if you don't mind going through the slides, a couple.
Hello, everyone. I'm Dr. Einav Acord. I'm an assistant professor and director of the reproductive psychology program at Cedars-Sinai in Los Angeles. Very happy to be here. Thanks for including me. You can go ahead to the next slide.
And Dr. Acord, don't forget to turn your video on if you haven't already.
Oh, yes, I have. Can you see me okay?
Yes, we can see
perfect. Thank you.
Okay, wonderful. All right, let's go ahead and begin. You might just want to click through the next few slides slowly. I don't have anything to disclose. And really what I'm sharing here are a few of the highlights from the past few years. If you want to just click through, aside from the obvious physical impacts of the COVID-19 pandemic, many people are struggling with the immense emotional and societal changes that it's brought. So many of us, I'm a psychologist, and my colleagues who are psychiatrists have reported an influx of people seeking mental health support during the pandemic, with really an unprecedented global health crisis, causing an increase in anxiety and depression, as well as exacerbating existing mental health conditions. So if the reproductive journey was challenging for some in the past, it has certainly been challenging for many more families in the past 2 years. Next slide. What I'd like to share with you all today is some information about the challenges to the reproductive journey, and not just focus on perinatal mood and anxiety disorders, but also the entire process from the moment that a family or a couple might decide to have children. So infertility is increasingly common. The prevalence of psychological distress is quite high in individuals, both men and women with infertility. Also, the process of having a healthy pregnancy might include multiple pregnancy losses. And regardless of the type or the timing, these losses can cause significant psychological distress, and individuals may continue to experience depression and anxiety for years following a miscarriage. And that's even after a subsequent live birth or healthy birth. Perinatal complications, for example, preeclampsia or neonatal complications, so babies ending up in the NICU, also place individuals at higher risk for perinatal mood and anxiety disorders. And these rates have increased significantly since the COVID-19 pandemic. Next slide. So to turn our attention, and thank you, Dr. Yonkers, for kicking this off and giving us some background information, I'm going to go ahead and add to that a little bit more. For those of you who may not be as familiar with perinatal mood and anxiety disorders, and in the past, we would really only ever talk about postpartum depression. And that is a major problem because essentially, anxiety is actually more common than depression. during the reproductive years. It's much higher in individuals going through infertility. It's also quite high in individuals who've had multiple perinatal losses. If you have a diagnosis like preeclampsia or gestational diabetes, or have a hemorrhage or some other complication, anxiety is going to be quite high. So we have to understand that these problems begin quite early, even during conception, during the pregnancy. And so talking about postpartum depression alone is really missing the bigger picture. So perinatal mood and anxiety disorders is what we speak about in the field. It encompasses a range of mental health disorders that do include major depression and generalized anxiety, but also post-traumatic stress disorder, obsessive compulsive disorder, panic disorder, and others. And these disorders, like I said, can begin during the pregnancy and last up to and even further than a year postpartum, considering lactation and when an individual may stop breastfeeding. So if one breastfeeds for 2 years, then they could potentially be at risk for developing a mood or anxiety disorder upon stopping that lactation. Perinatal mood and anxiety disorders are the most common complication of pregnancy, and left untreated can have truly devastating short and long-term consequences, not just for the birthing person, but for the entire family. And perinatal mood and anxiety disorders are associated with poor maternal health behaviors. So for those of you OB-GYNs on this call here, you might notice some of your patients not following your medical advice, not taking those medications, not coming in for their appointments. Perhaps they're smoking, perhaps they're abusing substances, perhaps they are not exercising or eating as you have recommended. And so we do need to be aware that this is a particular problem for this population. Next slide. As I mentioned before, anxiety is more common than depression in both pregnancy and postpartum. And the increase in anxiety has also been greater during the pandemic. So if you see this meta-analysis on the left side of the slide, showing the prevalence rates of both prenatal and postpartum anxiety as high as 24%, for example, you can see in the meta-analyses of studies most recently during the pandemic was higher than 30%. And so that's kind of what I was hoping to illustrate today, is that this has always been a problem, but we really need to be aware that our families are truly struggling at this time. Next slide. Focusing a bit on depression, I wanted to share this systematic search of the literature and meta-analysis that was conducted recently. So I showed it briefly on the last slide, a little bit more detail here. So these are from over 8,000 pregnant women from Germany, Israel, Italy, Poland, Spain, Switzerland, and the US that were enrolled. Sociodemographic characteristics, pandemic-related stress, pregnancy-specific stress and anxiety, and depression were all assessed with well-validated instruments, and a well-fitting common path model for the entire sample indicated that mood and anxiety disturbances were strongly predicted by pandemic-related and pregnancy-specific stress. And this is even after accounting for other maternal characteristics that we're well aware of. Next slide. So pregnant and birthing individuals in the US die at a higher rate than in other high-income countries, and reducing these deaths is a public health and a clinical priority. And what we have seen is that suicide is not just prevalent, but it's an increasing cause of death during pregnancy in the first year postpartum, and it receives far less attention than some of the other causes of death, hemorrhage and others. Most of these suicide deaths occur postpartum, the vast majority after the 6-week checkup. So again, it is critically important. Some of the issues that were mentioned earlier today, for example, the recommendation that Medicaid be extended up to a full year is really important for our maternal mental health crisis as well. And there are truly unacceptable racial and ethnic disparities in perinatal suicide deaths specifically, with American Indian and Alaska Native women at far greater risk. Next slide. So women from diverse backgrounds with perinatal depression encounter significant barriers to mental health treatment. There could be individual level issues like a trauma history, social related issues, perhaps not being able to get time off from work, and clinician related barriers to treatment engagement. For example, implicit bias and cultural humility, which really necessitates, care strategies that reduce stigma, offer convenience, and attend to cultural and economic factors. Next slide. There are significant, I see that this may be my older slide deck. Oh, well, that's fine. I had shared in a newer slide deck that there are significant challenges to PMAD identification and treatment, that pregnant and birthing persons in the US do face stigma and myths. And so there are many biopsychosocial risk factors that are interconnected. And the following indicators have truly the greatest effect on postpartum mental health outcomes. For example, biological, psychological, and social factors. What I would mention about that stigma and myths is that pregnancy and parenting are considered easy or intuitive or instinctive, which is not the case. And that pregnancy and having a baby protect women from intimate partner abuse and violence, and that is also not true. And so we want to make sure that individuals are getting the care that they need, and that we overcome some of those challenges to PMAD identification and treatment. Next slide. In addition to these key recommendations, so I'll run through these and then I'll just mention briefly what I had shared in a newer slide deck. But I recommend that we all get together to develop preconception mental health care. As I mentioned earlier, the reproductive journey does not begin when one is pregnant. The reproductive journey begins when a couple or family decides that they would like to have children. There could be infertility concerns, there could be multiple perinatal losses. And so we want to be able to support our families at a much earlier time. We need to do a better job assessing for suicide risk. And we want to speak more openly about suicide ideation and self-harm. A lot of good research has come out in the past 10 years looking at individuals with a trauma history, and that suicidal ideation is incredibly common in those who have that history. And so we want to be able to screen and assess and connect women to care, most importantly. But we can't connect women to care if that care isn't equitable. So we need to do more research on what works for who and when. What I will say is that screening alone is not going to cut it. So we need to be doing screening, education, referral to services, and then collecting data so that we can see what is working for who and when, and building those relationships of trust in the community with whom we are collaborating. Finally, we want to conduct demonstration projects in all of the relevant disciplines and sectors to determine the most important measures, protocols, barriers to, and facilitators for improving postpartum mental health care. And perhaps since these slides weren't included, I'd like to suggest that we discuss in the roundtable a little bit more on barriers to screening, education, and referral. Next slide. Thank you all so much. I appreciate your time and look forward to answering your questions, both within this roundtable and also anytime. Be in touch. Thank you.
Thank you. And it looks like we have Dr. Miller back. If we have your audio, let's dial back to the slides and start with you. Thank you.
Sorry about that disruption. It was a poorly timed computer crash, but you know, it tested my resilience, so maybe that's good for Dr. Yonker's presentation. So I am delighted to be here. I'm Emily Miller. I am an OBGYN, a maternal fetal medicine subspecialist, a health services researcher. I'm at Brown University Medical School and Women and Infants Hospital of Rhode Island. Next slide. And in terms of disclosures, I was the site PI for a COVID-19 vaccine in pregnant people. Next slide. I hope not to talk about COVID after having spent 10 days in isolation with my 6-year-old. Next slide. So as a health services researcher, and this dovetails nicely on the last talk, when I think about the care of women with perinatal depression and our ultimate goal of achieving remission of perinatal depression, I think about it in terms of the care cascade that needs to happen. So what are the steps that need to happen and who's responsible for what steps? So for depression to get to remission, we need the person to be identified. Typically that's via screening. They need to have initiation of treatment, and typically that happens via a clinical recommendation for treatment to occur. They need to have adequate treatment, so we need to recognize that that first treatment may not work and oftentimes doesn't, so we need stepped care. And then even then, we don't have the perfect tools in our toolbox to get to remission for everybody. Next slide. The data depicted here are meta-analytic data, relatively contemporary, that depict the percentage of women with perinatal depression across the United States. And what you can see is each step in that care cascade that leads to remission. And I want to highlight the fact that only 3 to 5% of women with perinatal depression will achieve remission of their depressive symptoms. And I just want to emphasize that because I think that number is so profound. Only 3 to 5% of people with perinatal depression get to remission. So we are failing. When I look at this bar graph, I reflect a lot on where are these big gaps. And there's an enormous drop-off in those who are identified via screening, and then another enormous drop-off in those who initiate treatment. And when I think about those are really in the rubric of us as obstetric clinicians. It's our responsibility. We're the ones that are in front of patients. And so how do we get to how do we improve things? Next slide. When I think about the overall reason why we're doing such a bad job, I don't think it's that we lack science or evidence or medical tools in our toolbox. In fact, I think each of these buckets, and this is just a part of the team that cares for people with perinatal depression, but we have some pretty sophisticated science. I think the overarching theme in my mind is that we're so siloed, that we have all this expertise within our realm clinically, and yet we don't interact with each other. We don't talk together. We don't work together. And I would offer that perhaps is true with research as well. Sometimes if I look at a publication, I see a whole lot of obstetric clinicians writing together, but they don't include subspecialists or perinatal mental health providers. And so I think with more interdisciplinary work, we might be able to advance fields a little bit faster, and that's certainly true in the clinical realm. Next slide. There's some pretty innovative health systems approaches to integrate mental health care into obstetric care. And so I've depicted a couple of them here. One of them is the collaborative care model. It's that little scheme on the right, top right, that shows the introduction of a care manager, a patient registry, and weekly team meetings, ways to systematically integrate mental health care and conversations with mental health subspecialists into the walls of obstetric care, ways to systematically and universally monitor people's symptoms to make sure everyone's doing better. Perinatal access programs are another really great health services approach that provide education, consultation, resources, and referrals. Again, ways to force or facilitate obstetric clinicians and mental health clinicians to collaborate together for patient care. Next slide. But I think there's still a ton of questions that remain. So for the collaborative care model specifically, we know efficacy and effectiveness data in primary care settings. But I would argue as an obstetric clinician, obstetric care is really different than primary care. On a lot of levels, there's efficacy data for collaborative care model in the perinatal context, but there's not effectiveness data. So how do we get to a place where we can look at effectiveness data? And along those lines, what are implementation strategies or implementation outcomes that we need to be looking at? And then thinking of the last few years, digital health or telehealth approaches, particularly when we have an eye toward postpartum, how can we improve access and leverage what we've built over the last few years with telehealth and digital health? And then this has been said, but can't be said enough in my mind. Oftentimes, when we look at structural interventions, they can improve population level health, but actually widen racial and ethnic disparities. And so I think it's imperative that any work we're doing in these models evaluates not only population level health, but also racial and ethnic subgroup outcomes. And then for perinatal access programs, what are best practices for their use? How do we expand them? Do we expand them? Should they be at the state level, region level, citywide? Does geography matter? Does population density matter? And how do these impact health equity outcomes? Next slide. I'd be remiss with talking about these health systems interventions without acknowledging how important education is. So as obstetric clinicians, we are surgically trained. We do not get a robust amount of mental health education in our curricula, at least from the perspective of medical school and OB residency. I think there's some really awesome educational platforms like the National Curriculum in Reproductive Psychiatry or Postpartum Support International that have geared training on reproductive psychiatry for mental health specialists. But I wonder whether we could convert these or adapt these intentionally for an obstetric audience. So what are the pieces of the puzzle that they need to focus on, and what is practical within the realm of obstetric care? And then where do we implement this? Professional schools, trainees, with practicing clinicians. So I think there's a lot of questions to be had there. Next slide. So remaining questions there, what competencies of care do obstetric clinicians versus mental health professionals implement, right? Which steps of that care cascade are best facilitated by who? And how do we organize care so that there is a handoff? What are best practices for continuing education and assessment of competency? And then I think we all know that adult learning and medical education isn't just read a module and learn everything and keep it retained, but what models of care support achieving these competencies in a sustainable way? Next slide. These look like old versions. So I think core points that I wanted to emphasize are key recommendations. I think pragmatic clinical trials to evaluate implementation of health services that facilitate de-siloing of care are really truly what we need. And then focused adaptation of medical education geared toward obstetric providers will allow us to integrate better into the mental health care continuum. Thank you.
Thank you, Dr. Miller. Dr. Wallace, when we get to the slides, thank you, introduce yourself, and thank you.
Yes, hi, thank you so much for having me here today. My name's Maeve Wallace. I'm a reproductive epidemiologist and Associate Director of the Mary Amelia Center for Women's Health Equity Research here at Tulane University in New Orleans. So it's great to be here with you today. Wonderful conversations already. I'm going to really briefly highlight some key points related to homicide of pregnant and postpartum women. And here I mean postpartum up to 1 year from the end of pregnancy. So I have one slide, I think, if you can advance. Oh, this is my title slide. Next slide. I have no disclosures to make. So starting out, I just wanted to lay this foundation that when I talk about this issue of violent maternal death, I always want to make sure that people are aware that these violent maternal deaths, are not included in counts and rates of maternal mortality. See those things reported. Maternal mortality only includes clinical or obstetric causes of death by definition. So, things like hypertension and hemorrhage. And so while my goal is to raise awareness of violence as a major cause of death among pregnant and postpartum people, it's never my intention to diminish or obscure the critical importance of maternal mortality prevention efforts. But rather, I think it's my view that if we can think far enough upstream as to in terms of deeply seated root causes, we can simultaneously address both violent and clinical causes of death and those deep-seated broader root causes that can be addressed to promote maternal health and well-being more broadly beyond just violence. So with that said, this slide covers some key facts and findings related to our work on homicide of pregnant and postpartum people. So drawing your attention down here to key factors, the white box on the left lower corner. So common across cases, what we've seen so far is that about half of these homicides are occurring postpartum, the other half during pregnancy. Most are the result of intimate partner violence, so that's about 70% across published studies. Those are not minus signs on the percents, those are little approximate signs, so approximately 70% are the result of intimate partner violence. The vast majority of these cases are the result of gun violence, so involving firearm as the mechanism of fatal assault. And 100%, all of these cases are preventable. And I really want to include that point because I know preventability is often something that is an issue that's up for debate in maternal mortality review committee discussions as they are reviewing cases. But without a doubt, every maternal homicide is a preventable case of maternal. So now just to draw your attention to the colored bar of epidemiologic facts on the right, quick quick overview again of the epidemiology. In terms of magnitude, we saw in a national analysis that homicide exceeds any single cause of obstetric death in its frequency. And troublingly, it looks like rates are on the rise, just as we've seen rates of maternal mortality rising since the CDC resumed reporting in 2018. We are seeing increases in maternal homicides since that date as well. In 2020, there were 5 homicides per 100,000 live births, which was significantly higher than the 2 previous years. And a couple other things to note about 2020, which I'm sure you all know was such a devastating year in this country and worldwide, given the pandemic and other social and economic disruptions that were all co-occurring. Homicide rates went up in the general population, crime went up that year, and we also saw increases in homicide among women who were not pregnant or postpartum, so just violence up in general. But the degree that the increase occurred was not as big as it was among pregnant and postpartum women. So really a vulnerable population when it comes to violent victimization. Also in 2020, we saw a higher percentage of deaths of violent deaths, maternal deaths involving gun violence. And so that tracks sort of with what we saw that year in terms of large surges in gun ownership and gun violence broadly in that year. And we're likely to see the same or worsening trends. In terms of populations most impacted, we see highest rates among adolescent, pregnant and postpartum people, as well as broad racial inequities, with high rates among Black women. These inequities are the result of inequities in bodily autonomy, unintended pregnancy, and of course racism that operates on multiple levels. We know that pregnancy itself can increase the likelihood that a woman is killed. And we see this time and time again in studies that compare homicide rates among pregnant and postpartum people to homicide rates among women or people who are not pregnant or postpartum at the time of their death. And so consistently higher rates among that the former group. And so that's really, to me, where we see the intersection of sort of violence and reproductive health, and this time frame in a person's potential reproductive trajectory being one that really opens them up to experiencing fatal violence. And finally, I just wanted to quickly emphasize that there are solutions to this issue. And so it's not just about documenting the epidemiology, but talking about what do we do about it. And so, a lot of the solutions don't and shouldn't focus solely on the pregnant or postpartum person, but intervening on multiple levels. For example, improving interactions and relationships, procedures and protocols between people who may be pregnant or postpartum and the healthcare or other service providers that they are encountering as a real window of opportunity to connect, to identify women in crisis and connect them to services. Implementing community violence prevention strategies, just more holistically thinking about violence prevention in the places that women live and work. And then enacting state policies that can directly prevent violent death, such as firearm ownership prohibitions for persons involved with domestic violence, or policies that improve the conditions that we know contribute to violence. So thinking about opportunities for redistribution of resources, for increasing income, minimum wage, employment, and educational opportunities across the population. So jam-packed a lot of information there into one slide for you, but I'll stop there and look forward to the discussion. Thank you.
Thank you so much. Now we'll go to Dr. Larley.
Thank you so much. I am honored to be here. Excuse my voice. I'm still in the midst of a family illness, not COVID, but lots of other things. So you can advance the slide. I'm going to shift gears a bit and talk about access to clinical trials, the ethical issues it raises, and its relationship to postpartum health. Next slide, please. I have no conflicts, but some of the work I'm presenting was supported by the National Institutes of Health. Next slide. So pregnant persons are routinely excluded from biomedical research, including research on mental health disorders. Exclusion has led to significant evidence gaps that harm childbearing people and their offspring. Exclusion also limits access to the direct benefits
of clinical trials. And although ethics has often been used as the reason for exclusion, ethical frameworks and regulatory guidance actually support robustly expanded inclusion of pregnant persons in biomedical research. Next slide. So this is a graph reflecting a study done by PregLac, which was or is a federal task force convened to advise HHS about evidence gaps for the care of pregnant and lactating women. So analyzing data over a 10-year period, they found a paucity of research across disease states, including mental health. For mental health, they found that less than 200 basic science KPD randomized trials and population database trials, in other words, trials that could inform clinical care, were done in mental health and pregnancy and lactation. So very little biomedical research in this area. Next slide, please. So patterns of exclusion have resulted in harmful evidence gaps. The first kind of evidence gap has to do with dosing. So we know that the pregnant body is different. It is physiologically different. It doesn't just look different. The physiologic changes in pregnancy can dramatically affect drug metabolism and effective dosing of drugs. Yet clinically actionable pregnancy-specific pharmacokinetic data are lacking. The second is, of course, fetal safety. For at least 9 out of 10 drugs on the market, we lack adequate information about their potential to cause fetal harm or about their likelihood that they are safe. The third is maternal outcomes. So when research is done with pregnant persons, it often focuses on fetal or neonatal outcomes without information on the impact of interventions on maternal health. A drug that is deemed safe for the fetus may be may be prescribed, but it may be harmful to the pregnant person. So without adequate evidence, pregnant persons are in harm's way in at least 3 ways. One, they may be given drugs at the wrong dose, so they are given either too much and experience toxicity, or not enough and continue to be exposed to the harms of untreated disease. They may be given drugs that carry unacceptable risk, either to them or to their fetus. Or they may be denied access to critically needed drugs. Next slide, please. So absent critical data, pregnant persons are denials of access relate to what I call reticence to take psychotropic medicines and other medications as well. So this is really the tendency in the absence of data for guideline developers, healthcare providers, and women themselves to be reluctant to use drugs, even where there are significant risks of untreated disease. So reticence is particularly strong in mental health contexts where we know untreated depression or anxiety is associated with harm to the woman or child. Those harms have been discussed at length before me, but such risks are often outweighed in hearts and minds by unknown or very likely small risks of drugs. In one 2013 qualitative study, one participant noted, "If I took an antidepressant, it would be on my conscience. It would kill me if there was ever something wrong. I'd worry, what if that was the cause? You just don't know what the impact is on the baby. It would be on my conscience forever." Next slide, please. In recent years, there's been increased recognition of the harms of excluding pregnant people from research. In its draft guidance in 2018, the Food and Drug Administration noted that filling the knowledge gaps regarding safe and effective use of drugs is a critical public health need. And the PregLac task force that I mentioned before noted that a cultural shift is necessary and that research on therapies for these populations must be facilitated and greatly augmented. Next slide, please. So clearly, actually a paradigm shift is underway. In charting a way forward, our group identified 3 emerging conceptual shifts in the ethical framing of research. The first is a shift from the historical designation of pregnant persons as a vulnerable population. Obviously, we've talked about some vulnerabilities that pregnant people experience, but this means something very different in the research context. So it is a designation in the research context that is formally shared by children, prisoners, and individuals with intellectual disabilities. So not only is the term vulnerable inaccurate, nothing about pregnancy itself interferes with a person's ability to make decisions for themselves, but it has had an unintentional chilling effect on research. So in 2018, the common rule, which guides biomedical research, removed pregnant persons from the list of people considered vulnerable. Now ACOG and others recommend the term complex population to describe pregnant people. The second shift is an emphasis on protecting pregnant persons from research to protecting them through research. And the third is a shift from presumptive exclusion to fair inclusion. So pregnant persons deserve both a fair share of the benefits of public and private investment in research, and also fair access to trials. Next slide, please. So research with pregnant persons can be justified on very strong foundations, ethical foundations. Our group has articulated 3 of those. The first is equitable protection from research risk. Equitable protection from the risks of drugs. So an animating mission of all of research is to gather evidence in controlled context to decrease risks in clinical care settings. Pregnant persons deserve this protection alongside other populations. They have not had it. The second is access. Pregnant persons deserve timely access to first-line and optimal medications. As we've seen, because of gaps in data, they don't have this access. And the third is respect, which relates to the fact that attention to fetal and child outcomes can outweigh attention to maternal health outcomes. So research involving pregnant persons must engage them as ends in themselves and prioritize their health interests as key study outcomes. Next slide, please. There are remaining challenges, and I won't take a lot of time to discuss these, but I've listed them here. But they have to do with the interpretation of risk, especially in pregnancy, cultural narratives around pregnancy and motherhood, as well as cultural narratives and misunderstandings about mental health. Next slide. Against backdrops in which we have a very difficult time thinking about risk as well as about depression in pregnancy, communication is particularly important, and I would offer that it can be improved. So as we start getting these data, we need to think about how we communicate them. So for instance, look at this recent headline in October, association of antidepressant use during pregnancy with risk of neurodevelopmental disorders in children. The findings of this study were that antidepressant exposure during pregnancy was not associated with autism spectrum disorder, ADHD, specific learning disorders, etc. So the way that this is framed, this so-called neutral language in the context of our worries about risk and medications in pregnancy is not in fact neutral, but it implies something that it implies that there is risk associated with medicine when there is not. So this neutral language can be misleading. We have to think about that. Next slide, please. So my key recommendations are that we need to address evidence gaps in maternal mental health through timely and responsible inclusion of pregnant persons in biomedical research, and adhere to the ethical principles of protection, access, and respect. Apply recent recommendations from PregLac or from the phases work that I've done to mental health contexts. Measure and report benefits and harms of interventions for treatment of mental health disorders in research and clinical care, and improve communication so that it is responsive to the pregnancy mental health context, including the absence of association with harm where none is observed. Next slide. So I will end with this slide. This is a picture of Frances Kelsey, who is famously the FDA official that stopped approval of the drug thalidomide in the US. She's getting the Medal of Honor here from President Kennedy. And I've been doing some work with another colleague named Miranda Wagner and looking at the the Kelsey Archives, and what she said in 1968 was that it would be unfortunate if fear of adverse effects to the offspring deprived the mother of drugs that might be essential to her well-being, and indeed possibly also to the successful outcome of pregnancy itself. Okay, that's it.
Well, great. Thank you. Thank you very much. Thank you to all the panelists. I want them to please turn on their cameras, and we're going to have a brief discussion. We're going to go until 2:35. As we get cameras on, just to quickly, sort of summarize a lot. There's such excellent talks. But Dr. Yonkers, you were talking a little bit about sort of the stress test of pregnancy. You touched on interpersonal violence. You talked really about how among behavioral activation, only a third of people are actually assisted. Dr. Accord, you grounded it in COVID, and you expanded our lens to include what you called the reproductive journey, in particular the preconception period, and also mentioned how pregnancy and parenting are not natural and easy to do. Dr. Miller, you're talking about the care cascade, again, sort of identifying, that only 3 to 5% of people achieve remission, and really showed well how siloed care inhibits, really public health. Dr. Wallace, drilling down on homicide, and really, I think the person who focused the most on policy level interventions in this clinical space. And finally, like Dr. Lyerly, really talking about ethics and how, in some ways, gender bias in ethics leads to the exclusion of pregnant people in research, and showing a path for sort of fixing some of this. And I really liked the, shift in the language from vulnerable to complex, and how thinking about sort of protection through research, and how we, might pay attention to how we communicate risk and pregnancy and et cetera. So if, any of the panelists, you want to type in some questions, I'll take a look at them. I've looked at the chat, but I thought I would really begin by just talking or asking about violence, which many of you touched on, both, interpersonal homicide and et cetera. And first, to kind of go upstream, that was touched upon, to causes of violence, in particular, perhaps to bring greater attention to structural sexism, and then to go downstream to think about what does prevention look like, in something that is really, as mentioned, 100% preventable in terms of violence. So I don't know if somebody wants to go first. If not, I will call on the person on my screen first, which is Dr. Wallace.
Sure. Thank you, Dr. Turplin. Yeah, as you mentioned, I sort of focus up on the policy level. I'm an epidemiologist, so very much higher level population health thinking, and where to make the biggest impact. So some of our work, like I mentioned, has looked at firearm prohibition policies. So really removing the gun from the situation is, a direct way to make a situation less fatal. But I also, I'm interested in the social and structural determinants of both maternal mortality and violent maternal death. So knowing that those root causes, things like you mentioned, gendered racism, income inequality, all the intersectional oppressions that really shape who has power and who doesn't in our society, are what underlie sources of violence in the community and within a household or within an intimate partnership. And so addressing those with policies that can dismantle structural racism and allow for equal access and equitable access to livable wages, safe housing, safe communities, and all of the things that have been shaped historically by and ongoing structural racism. Another thing I wanted to mention that I think I failed to initially was this whole piece about pregnancy increasing risk and the need to ensure that women are able to control whether or not they remain pregnant. And so, threats to bodily autonomy and access to abortion and the ability for a person to decide to continue a pregnancy or not is so critical, especially when it comes to these violent situations in which there might be truly life-threatening consequences tied to that decision. I'm curious to hear from other panelists.
So go ahead.
I would say that a lot of what we see in instances like this are a distillation of what's going on in the society around us. And we see it magnified in this particular instance. So, clearly violence against female individuals is nothing, against individuals, period, but particularly women is nothing new. And of course, it can happen in pregnancy. It's not always avoidable. Just as we think that people in certain situations can just leave the home or just leave the relationship, it's far more complex. I think having the structures available to help people can, in many instances, move individuals to that next step. But it is really a complex situation. Certainly, getting a handle on violence in the community, period, would help our perinatal individuals who are also being subjected and perhaps in certain instances overly subjected to violence.
So I want to sort of build a little from both of your responses to talk, because it was mentioned sort of reproductive health policies, threats to autonomy, in particular abortion restrictions. And if you could comment on how those policies might play out for behavioral, perinatal, and postpartum behavioral health in particular, as well as like around maternal mortality, if you have reflections on that.
I mean, I guess I'm happy to offer some worries, right? I think I'm grateful to Maeve for bringing it up. I think what we've already started seeing is that restrictions on access to abortion are putting pregnant people in harm's way, not just because of sort of not having access to, certainly because of not having access to life-preserving care. We've heard many stories of women being denied pregnancy terminations when they have ruptured membranes, ectopics, etc., but also being forced to carry pregnancies that do not have a chance of survival to term, not being able to choose when and how to give birth or to end a pregnancy, clearly is going to create tremendous stress for women and have profound mental health impacts. So I think we're just starting to see what's happening, but I'm worried that it's going to get worse before it gets better. And I think we just have to remember that as somebody said, and after that person in Savita from Ireland died, she has a heartbeat too. So we need to think about the lives put in harm's way when abortion is illegal.
Thank you, and then thank you, for speaking to this. We just have a minute left, and I really just want, if there's any, Dr. Court, I want to give you an option to speak. I think we lost Dr. Miller, and any sort of final reflections and/or sort of focusing on sort of interventions. You had mentioned sort of screening, referral to treatment, but if that from sort of a interdisciplinary, horizontal kind of perspective, or whatever you want to say. I can't hear you.
Mishka, can I make a comment about
Yes.
about Dr. Lyerly's presentation, which was they were all wonderful presentations, but I think one of the sort of ways to address this is also to figure out what opportunities there are to work with pharmaceutical companies because they don't do adequate reproductive safety testing early on. You know, there are limitations in what they're mandated to do. And then there's often a behind the scenes war where one company will take another company's compound and make it purposely look crummy, so that the company A doesn't really want to pursue something that may not work out well. So, you know, if there were some way to look at an opportunity for mandated, a certain mandated level of testing that is a higher bar before the particular compound is rolled out to a larger group, I think that would be that would help move this forward a little bit. But I mean, I think this group is absolutely right that there has been a focus on the fetus without a focus on the mom in many instances, not always. And I think we need to make sure that we're addressing the needs of both parties. There was the Treating for Two initiative at NIH, which was really strong and really helpful. And I don't know what's going on in that space now.
Well, thank you. And with this, I'm going to turn it over to the panel for their questions.
Thank you so much, Dr. Turpin, and all of the panelists. As I mentioned before, we're going to start with questions and comments to the panel from the P2P panel members. So Dr. Epling, I see that you had a question. If you're able to unmute and ask the panel your question, we'll start with you.
Yeah, thanks. My question was directed toward Dr. Miller, but I don't know if she's still on or not. But anyway, it's about the the handoffs and transfers of care between settings. Family physicians and other health professionals in the primary care space provide a lot of primary care across the country. This transition between perinatal care, postpartum care to primary care often gets a little sticky with especially with mental health concerns that obviously have urgency right after delivery. So I wondered if Dr. Miller knew about any research that looked at the quantity and quality of quantity and quality of referrals, warm handoffs, those type of things in helping bridge this gap between obstetric gynecologic providers, some of which do primary care, some of which don't, and I think have some variety there, and those of us tasked with regular primary care. I wish I could say that family physicians were doing more maternity care and establishing that continuum, but I'm afraid we're seeing trends that speak in the other direction.
Any panel members who want to comment on that? I think Dr. Miller's still having audio problems.
Well, I could say here at UMass, we're the home of MCPAP for Moms, which is the perinatal access program that's very much like the child psychiatry access program. And one of the drivers, and I've participated in it before MCPAPs, is the failure when you try and refer an individual for treatment outside the treatment setting where they're already getting treatment. So when you look at the attrition moving from one setting to another, it's really, really problematic. So that argues for trying to keep the treatment as you know, in one site as much as possible, and to increase you know, innovations like a perinatal access program, which I assume you know what that is, which is, you know, an OB-GYN or a reproductive health practitioner has a patient in need of an evaluation or treatment for a psychiatric illness, whether it's a mood or anxiety disorder or substance use disorder, and they can call a hotline and they can get some advice right then and there about the individual who is pregnant. So that is a real success story. And, you know, my personal feeling is we need to expand that and build on that because that is successful. And it hits on 3 different levels. It increases capacity because the person who is calling the warm line, after they've seen a few individuals who have very similar profiles in terms of their psychiatric condition, then they feel more comfortable and more empowered to go ahead and treat that individual without having to make that phone call, right? So it increases capacity. I think it keeps the treatment in one setting, which we know is much more successful. And then the third thing is one of the things that we have to acknowledge, I think, is that people are busy and they have a lot of patients to care for. And as much as we hate to admit it, there are people who see a patient and say, this is going to be a lot of time and a lot of effort if I ask this question. So maybe I'm better off not asking this question. I can get out of here before 8 p.m. But if you have somebody that you can call, then, you can get that assistance right then and there. So I really think that the perinatal access program model is strong, and you're more likely to do a handoff to primary care, when somebody is stabilized and when the primary care provider can just, rewrite the prescription if need be. And that relates to pharmacology. Of course, psychotherapy is a different issue, but.
Thank you.
Terrific.
Not sure if you can all hear me now.
We can.
Oh, wonderful. I just wanted to add one piece. I heard part of what Dr. Yonkers was saying, and I couldn't agree more. And I wanted to share too, just to piggyback off what Dr. Miller had mentioned about the siloed nature of this care, and that if we perhaps as psychologists in an OB-GYN department worked closely with the obstetrician, gynecologist, maternal fetal medicine experts, psychiatrists in the hospital, pediatricians, we would do a better job to remove the siloed care that we receive, working together to be able to provide, as Dr. Yonkers mentioned, that warm handoff within the system. And so there are a lot of different models for doing that. I think the main point is to get us all talking to one another, as opposed to just to each other. And so I wanted to thank, the organizers of today's meeting for doing that, because that's exactly what's happened. Is now we're talking to each other across the different disciplines, as opposed to being our own audiences. I've put in the chat a paper that we published that included over 20,000 births at Cedars-Sinai over a 2-year period in our postpartum depression screening, education, and referral program, where we worked together with OBs, MFMs, the nursing staff, NICU, and so forth, psychiatrists. And so, as Dr. Miller mentioned, it's not just a bunch of psychologists who authored the paper, but each one of us in our separate disciplines. And I encourage you to take a look at that.
Thank you. And actually, while I have you, Dr. Accord, I'm now reading some of the questions from the chat. Again, if panel members, the P2P panel members have any questions, please let us know. But we have one question from our audience about whether screening for perinatal depression, specifically the PHQ-9 and the Edinburgh postpartum depression, have been validated in BIPOC populations.
Yes, they have, and they're very effective in picking up depression, specifically depression and anxiety with the Edinburgh. So I highly recommend using the Edinburgh over the patient health questionnaire, because it addresses anxiety, as I mentioned, which is more common. There is some research that's come out in the past 10 years or so that's looked at a lowered cutoff for BIPOC individuals. And so that's one thing to consider. But what we've done is made sure through our multiple training initiatives that women and birthing persons in our hospital, regardless of race, feel comfortable answering these questions, because the biggest issue is coming in and saying, we're screening you for depression and we're going to call a social worker. There's a lot of concern, particularly in BIPOC communities, but really across the board, that new parents are worried that, well, if I answer all these questions, and honestly, this nurse is going to call social services and take my baby away. And so that's really something we've addressed within our training modules so that we don't even use the word depression. We talk about child and family wellness at Cedars, and the nurses really point out that the purpose of this screening is to connect you to care, hopefully within our reproductive psychology program, but if not, in your community. And so I think that's the real take home, is to make sure that the individuals feel comfortable answering honestly and openly, because, you know, they understand, why are you asking these questions? And it isn't to get anyone in trouble, right?
Yeah.
Because that's happened in the past.
Of course. So I'd love to have the whole panel discuss this sort of structural problem that we have that is again emanating from a comment from the audience, that currently there aren't enough mental health professionals to deal with the psychiatric and psychological issues of the general Medicaid population. And so what can we all do together to enhance or build infrastructure so that as we add perinatal and postnatal psychological issues and follow-up, appropriate follow-up, we're not just creating another problem?
Yeah, I mean, I think, you know, part of what I was saying before about access programs helps with this. But right now, I think it's fair enough to say we're having a crisis in this country in terms of the access to behavioral health care. And there are multiple reasons for that. Of course, one of the reasons is that we don't have enough mental health providers. We don't pay mental health providers adequately. And we certainly, it's not just, here's a news flash, it's not just people who have Medicaid who can't get a mental health provider. It's people with commercial insurance can't get a mental health provider, at least a psychiatrist, in many parts of the country because the reimbursement is so poor. So, you know, I think one of the things that we need to take a look at is what reimbursement strategies are like and how to make those favorable enough that people will actually want to practice in the field, and particularly for people who have non-commercial insurance, who have public insurance. That is a real need. And we need to expand the pool of behavioral health providers. And we need to do the sorts of partnerships that we've been talking about today, whether it's an access program or whether it's an embedded program or a collaborative care program, so that people can receive the care that they need and they are due in this. There's a lot of health inequity. And this is, again, a microcosm of where we see it. So half of pregnant individuals are covered by public insurance. That's 50%. So these are people who are less likely in any scenario to get mental health treatment with the insurance coverage that they have.
I think I would just add one other piece to that. So well said. I think for us at Cedars, we found that having group options, so group psychotherapy, support groups, they're not peer-led. These are led by PMHC, perinatal mental health, certified therapists. And we make sure that these are affordable, so they are cash pay, and we have discounts for someone who has Medicaid or other public health insurance, to where it's truly less than what one would pay a copay for individual therapy, certainly. And so we're trying our best to kind of think outside the box to provide at least some assistance, some help to individuals who really do need that mental health support. Perhaps while they're waiting, many of my patients wait months to see me for individual cognitive behavioral therapy. And so what are they doing in those months of waiting? Well, we're only pregnant for 9 to 10 months, right? So we're only lactating for 9 to 10 months. So we can't wait months and months and months to get in to see someone, but perhaps a group approach allows you to sort of bridge the gap until you can get seen by an individual therapist. And the medication piece, Dr. Yonkers, is truly it's a catastrophe that we cannot get are patients seen by psychiatrists in a timely manner, and that there aren't enough reproductive psychiatrists to collaborate with. Big problem.
You're on mute, Dr. Miller.
Lord help me with this audio. It's gonna just.
We can hear you.
I'm trying to do this on my phone. We're gonna just do multimodal here, but I just wanted to chime in, and I'm sorry my computer keeps acting up with WebEx, but just wanted to emphasize the role of capacity building for obstetric providers, and that might have been covered earlier, but I think while obstetric providers are probably not your best source of psychotherapy, although I do think that is a part of early career development that you end up learning a lot of skills. I do think the pharmacotherapy for basic perinatal depression and anxiety is within our wheelhouse if there is a support infrastructure like an integrated health program, collaborative care model, perinatal access program. So I think that is one avenue to bridge some of these gaps, because I don't think, I'd love to hear people think otherwise, but I don't think there will ever be enough perinatal psychiatrists available. But I think that's where if we learn together, if we do capacity building, I think there is scale. I also think from an insurance standpoint, you know, we're seeing pregnant people with all insurance types, and there's a little bit less of carve outs with that. So I think, again, capacity building for OBs is something we should invest in and heavily lean on.
Somebody in the chat mentioned the Centering for Pregnancy program, which is group prenatal care, and that actually is another nice model for at least helping people with less severe mood and anxiety symptoms.
Terrific. Well, this, I think, has been a very robust discussion of both the enormous behavioral health need and unmet gaps in both our structure and our capacity. But on the hopeful note that there are ways to think out of the box and evidence that when we get care to people, they improve. I will close this session. Thank all of the round table members for their great presentations. For everyone else, please stay on WebEx, but we're taking a 12-minute break if everyone can be back at 3:05 p.m. Eastern time, and you can just mute and stop your video.
Thank you.
Thank you, everyone.
Thank you.
Talk to you soon. Okay, everyone, welcome back from break. It's 3:05, so we'll get started again. It looks like the break clock froze. So we unfortunately don't have 6 minutes left, but we'll get started now. So for the rest of today, we will cover key question 1, which is at a birthing person's entry into prenatal care, what combinations of risk indicators have the greatest effect on poor postpartum health outcomes? So Dr. Jamie Slaughter-Acey will kick us off with the presentation from the Systematic Evidence Review on key question 1. And Jamie, I will turn it over to you.
Wonderful. So thank you all for having me. I'm Jamie Slaughter-Acey, Associate Professor at the University of Minnesota School of Public Health. Next slide. And I do, I guess my one disclaimer is that this presentation is based on a report of research conducted by the Minnesota Evidence-Based Practice Center. Next slide. So I want to acknowledge my co-investigators and the transdisciplinary nature of our team. Next slide. All right. So as many of you know, maternal morbidity and mortality rates in the US are increasing, as too is attention to addressing contributing social determinants of health. The sponsoring institutes for today's workshop asked the University of Minnesota to conduct a review of literature on social and structural determinants of health and maternal morbidity and mortality. And today I'm going to be presenting part of that evidence map based on our review to help us understand how research has approached the topic to date. Next slide. So social determinants of health represent the conditions or circumstances in which people are born, grow, live, work, and age. Next slide. Social determinants lie downstream from structural determinants of health, the structural forces that shape how social determinants are experienced by people in their neighborhoods and communities, and the ways that resources and quality are distributed across individuals and communities. And together, these social structural determinants of health work to shape and promote maternal health for people across different levels of influence. Next slide. So before I dive deeper into our methodology for the evidence mapping, I wanted to briefly touch on terminology. So both terms labeling racialized people and marginalized groups, as well as medical diagnosis terminology, have shifted over the years. And in both of these cases, we use the same language with which the study author presented their results. We seek to highlight the fact that perception, sorry, next slide. We want to note that all people who give birth do not identify as women and have attempted to use gender neutral language. However, when citing a specific study outcome, we use the study specific language. We also seek to highlight the fact that perception in, sorry, next, oh, no, stay on that side. We also seek to highlight the fact that perception in the case of or act of recognizing the presence of discrimination is a necessary step of appraisal. So we use the word reported rather than perceived discrimination. Next slide. Next slide. So our key questions, key question 1 focuses on pregnant people, and it is from a pregnant person's potential entry into prenatal care. What combinations of risk factors have the greatest prediction of poor postpartum health outcomes? And to what extent did these patterns of predictors of poor postpartum health outcomes vary by person's race, ethnicity. Next slide. Key question 2 focuses on birthing people and asks immediately before, immediately after delivery, and before release from birthing-related hospitalization or clinical care, what combinations of risk indicators of the birthing person have the greatest prediction of poor postpartum health outcomes? To what extent did these patterns of predictors of poor postpartum health outcomes vary by race, ethnicity of the birthing person? Next slide. So for our search strategy to identify for the literature that we identified as relevant to the key questions, we used the following PCOT framework. Next slide. Okay, and so in using the PCOT framework, our populations, the only major difference between key question 1 and key question 2 with respect to population exposure, outcome, timing, and setting is with population. In that key question 1, remember, focuses on pregnant people, their potential entry into prenatal care, and key question 2 focuses on birthing people just prior to, during, or immediately following delivery, but before release from birthing settings. Next slide. Our search strategy for the literature relevant to our key question. Okay, so this is our search strategy for that literature relevant to key questions in terms of the databases that we use, Medline, CINAHL, and we used, combined searches with identified vocabulary terms. There was no restrictions on publication dates, and we limited studies to those that were reported in English. Next slide. So decision roles. Studies were included. We included studies that included a social determinant of health as a control Studies that included a social determinant as a control variable were excluded, and studies must measure pregnancy at or beyond 20 weeks to be included. Finally, included studies focused on interpersonal factors as opposed to intrapersonal factors. Next slide. Risk of bias. So we subjectively prioritize studies according to study design and rigor of analytic approaches to address selection bias based on Robbins E. We determined that all included studies were high risk of bias from a causal standpoint. Therefore, we continued with the review from the perspective of supporting future researchers in generating hypotheses for risk factors as the basis for potential interventions. Next slide. We categorized studies into major social determinant of health exposure domains based on what was available in the identified literature. And this presentation today focuses on the domains of identity and discrimination and comorbidities. Next slide. So we used alluvial graphs or braided rivers to map the identified literature, and graphs demonstrated the number and interwoven variables represented in the literature set that we identified. Next slide. Each line on the alluvial graph in front of you represents a study. The outer columns are the domains in which we categorized or grouped studies, exposures or outcomes into. So for example, on the outer left column, that is the social determinant of health domains that we grouped based on what we found in the identified literature set. And on the outer right column, that is the outcome domain that we grouped based on the outcomes that were present in the literature set. The inside columns of exposure and outcomes are how each specific study talked about their measures. Next slide. Next slide. So we identified more than 8,000 records in our search of databases. And upon screening and critical appraisal, we included 109 studies for narrative synthesis. Next slide. This slide shows the categories of data sources that were used in those 109 studies that were synthesized. Next slide. And this slide presents the number of identified studies per each key question, outcome domain, and special populations that the study may have focused on. Outcome domains represented in studies included cost or healthcare use, cardiometabolic disorders, depression, diabetes, hypertension disorders. Next slide. Maternal mortality, substance use or mental health other than depression, severe maternal morbidity, and weathering. Next slide. Okay, so excuse me, our overall, some overall key points were that first, included study exposures broadly covered the social structural determinants of health, yet they only represented a subset of the potential social structural determinants and did not address intersections between or intersections with biomedical risk factors. There's also limited depth and quality of available research within each of the social structural determinants domains that we identified, and that includes studies focusing on racism or other forms of discrimination. We did find an unexpectedly large volume of research on violence and trauma relative to other potential social determinants of health. And then among outcome domains, depression and other mental health outcomes were a large portion of health outcomes captured. And then lack of depth in conjunction with the wide array of breadth of social determinants that were covered impeded our ability to understand mechanisms or pathways that connect the social determinants of health, medical comorbidities, and maternal health outcomes. Next slide. Okay, so now it's time for our braided rivers or alluvial graphs. So for our first domain, identity and discrimination, for our first KQ or key question, which focused on pregnant people, we found a total of 28 studies that included a measure of identity or discrimination. Next slide. And just a reminder on our alluvial graphs or our braided rivers, one study or one line represents one study outcome. And then within the social determinants of health domain of identity and discrimination, the largest outcome domain represented was depression, studies related to depression, followed by those studies that focused on severe maternal morbidity as an outcome, and then hypertensive disorders. Next slide. Of those studies, only one reported the excess attributable risk to a specific exposure. This study reported that income inequality was associated with a 14% increase in excess risk of death for Black women relative to white women in Virginia, and that prolonged 5-year income inequality was associated with a 20% increase. Next slide. All right. So the key question 2, which focused on birthing people, we found a total of 16 studies that included a measure of identity or discrimination. Next slide. And within the social determinants, within the domain of identity and discrimination, the largest outcome domain represented was severe maternal morbidity, followed by maternal mortality, and then cost or healthcare use. Next slide. So in the set of literature, few studies reported the excess risk attributable to a specific exposure. Very recently published studies reported that Hispanic birthing women were more likely to deliver at hospitals with higher risk-adjusted severe maternal morbidity, contributing up to 37% of the ethnic disparity in severe maternal morbidity in New York City. Combined race and income segregation was associated with increased severe maternal morbidity in birthing women in New York City, and delivery hospital accounted for 35% of the attributable risk, and comorbidities 50%. And then another study found that nationally, if rural indigenous birthing women experience severe maternal morbidity and mortality at the same rate as urban white women, they would see a 49% reduction in cases. Next slide, yeah. So in terms of our domain of comorbidity factors, for KQ1 on focusing on pregnant people, we found a total of 7 studies that included a measure of comorbidities. Next slide. So within this domain, the largest outcome domain represented was depression, followed by maternal mortality and weathering, or cumulative allostatic load. Next slide. So for key question 2, we only found 2 studies that identified or included comorbidity, and next slide. Next slide. So the moral of this story is that messiness is necessary. The more braided the river, the more information we have to understand the interrelatedness of factors. And we're trying to capture, and the point of it is that we're really trying to capture the complexity here rather than reduce it. And that this topic we're all here today focusing on is quite complex, and our groupings are subjective in each presentation that we'll be making over the next couple of days. And they're based on what we found in the literature. And other investigators may group things slightly different. Next slide. So just some limitations of our review. Included studies were required to have examined the impact of a social determinant of health. So we excluded many studies that focused solely on comorbidities and medical approaches as risk factors, and and the delivery of perinatal care. Second, because of our wide scope, we focused on quantitative epidemiologic studies or similar research. And then if the included studies did not fit cleanly into discrete groups, that was a limitation that we found as we were synthesizing the literature. And so that really required us to be more subjective in the categories of exposures that were created. Next slide. So there's several places where future research is needed. So there's a need for additional research focused on the impact of social structural determinants of health on maternal health to inform prevention and intervention. And this work really must move beyond the research silos and interdisciplinary silos that exist presently. There's a need for research that expands the domains of social structural determinants of health examined, but also includes mechanisms and pathways by which the social determinants of health impact pregnant persons and birthing individuals' care and outcomes. So this review represents only the cusp of social determinants of health and maternal health research that is sure to come. Next slide. And there really needs an organized and curated catalogs of maternal health exposures and their presumed mechanisms could facilitate future examinations of exposures. So research, we need researchers that can name the forms of racism being examined, the mechanisms by which those forms of racism work, and other intersecting factors that may compound the effect of that form of racism. And then lastly, researchers can improve adherence to basic reporting standards. Make it easy to identify high quality research and how it contributes to the field. Next slide. Next slide. So here is a link to the full report, which is open for public comment through December 4th. And we look forward to hearing from you. Thank you.
Thank you very much, Dr. Slaughter-Easy, for that summary of the draft report. We really appreciate it. As she said, the draft report can be found there. There's also a link to it on the ODP website, which might be a bit easier to find, and we can put that link in the chat since it's shorter. We will now turn to our three speakers for key question one today. And kicking us off will be Dr. Mishka Turplin, who's coming back for the second time today. Thank you, Dr. Turplin.
Hi, thank you. Thank you. I'm going to talk about improving care of substance use disorders to improve maternal health. My name is Mishka Turplin. I'm an obstetrician gynecologist. I'm an addiction medicine provider. I'm the medical director of Friends Research Institute. I have no disclosures. So really, pregnancy is a critical moment for addressing substance use disorder. It's a time of near universal insurance and access in the United States, as well as increased contact with the healthcare system. The pregnant people have unique needs related, as we've heard, to physiology of pregnancy, as well as to gender roles of pregnancy, parenting, and childcare. And in many ways, the time of parenting and postpartum is when we withdraw and abandon support. Hence, federal policies, as well as healthcare practice, as well as research, are misaligned with chronic disease management, with the realities of the postpartum period, and with the rights and dignity of parenting, in particular for people who use drugs. But most people who continue to use a substance in pregnancy likely meet criteria for a use disorder. And addiction is a chronic, medical condition defined here from the American Society of Addiction Medicine. And we know when we treat addiction, just like any chronic disease, birth outcomes improve. These are data from the state of Massachusetts, contrasting people without SUD to those with treated disease versus those with untreated disease. And you can see the weight of the population health burden is really amongst the population with untreated disease. And people with treated use disorder look more like, or sometimes are identical in many ways, to people without addiction. But most people with use disorder receive no treatment. In general, in the United States, it's 11% of people who meet criteria for use disorder report receipt of any treatment in the past year. It's slightly higher in pregnancy at 13%. And for opioid use disorder, that's the addiction that is the most treated and more likely to be treated in pregnancy than anywhere else. Only a third of people with opioid use disorder receive any treatment in pregnancy. And treatment is inequitable across populations. On the top left, these are data looking also from the state of Massachusetts, looking at the odds of receipt of any medication for opioid use disorder. And you can see Black non-Hispanic pregnant people have 0.4 times the odds of receiving any medication compared to white non-Hispanic pregnant people. And this reflects, structural racism. And on the top right, this is really looking at, discrimination within healthcare settings that might be grounded in scientific racism, looking at mean methadone dose for people with opioid use disorder at the time of delivery. And whereas white people received a mean dose of 145, Black people received a third less of less than 100. And obstetrician gynecologists lack the workforce to treat opioid use disorder. This is looking at the number and the proportion amongst all OBGYNs who are ex-waivered, i.e. waivered to prescribe buprenorphine. And it's less than 2% of obstetrician gynecologists are able to prescribe buprenorphine. So as Dr. Clayton mentioned in her introduction, this is really, pregnancy is part of the life course. And it's really this life course perspective that in many ways it illustrates gender inequities across the lifespan. For example, we provide episodic health insurance related to pregnancy, i.e. valuing a certain aspect of a person's life course over the other aspects. And it's really that transition from pregnancy to postpartum that is most critical in many ways for opioid use disorder. These are data from the state of Massachusetts, also looking at all overdose events, not just fatal overdoses. And you can see rates decrease through the course of pregnancy, only to increase postpartum. And they continue to increase, this would be unpublished data now, into the second year postpartum. And those at the end of the postpartum period, rates of overdose events are higher than they were in the year prior to pregnancy. And we've, touched on, it's been mentioned that, Medicaid expansion is helpful. But I want to make the point that health insurance is not health care. And that in many states that have expanded, Medicaid postpartum, the denominator of eligibility changes and not everyone continues to actually have coverage. And the only state that I know that applied that, without that recalculation is Illinois. So there are unique, sort of intersections around when we talk about birthing and drug use. In particular, how it intersects with sort of the policing and the surveillance of the child welfare system. And this is codified to some extent in federal and state statutes, in particular CAPTA, the Child Abuse Prevention Treatment Act. And this act, in many ways, this policy is misunderstood, I think, by health professionals. And that sort of misinformation around CAPTA is operationalized through a misuse of drug tests during the birthing hospitalization. So I was trained as a medical student, you only order a test, one, that you can interpret the results of, and two, that's going to inform clinical decision-making. And there's evidence that health professionals do not properly interpret drug test results. And I would ask, what is the clinical utility of routine drug testing during the birthing hospitalization? And most of the time that test is being ordered under, a false understanding of that it might be required by federal or state law. It rarely is. Usually there needs to be, and second, under this sort of false assumption that universal testing reduces inequities. And there's other data to demonstrate that that is not true. So health professionals are really the largest reporters to the child welfare system for children less than a year of age. And the overwhelming reason for the report is due to parental drug use. And whereas reports into child welfare have remained unchanged from schools, police, families, and anonymous over the last 15 years, they've increased some 400% from health professionals. And you can see here on the right-hand side, these are unpublished data looking at, infants who are screened in by child welfare authorities over time, the marked and increasing racial inequities in reports, with a profound increase in American Indian, Alaska Native children, and an even more rapid rise in the reporting of Black infants more recently. And these sort of, racial inequities in drug testing lead to sort of a selection bias in child welfare reporting, and racial inequities in family separation, and ultimately in termination of parental rights. And that's sort of the simplified child welfare pipeline that I depict here. And I want to stress that the termination of parental rights, which on the top left, it's hard to read. You're looking at rates stratified by race and separated by state. There are many parts of the United States where even American Indian or Black parents have rates 5 times or greater of termination of parental rights. And when that happens, the birth certificate is rewritten. The birth parent is erased from that document and a new one is generated. And that is something that's been described as, like a civil death penalty, and described as grief and loss, both of the parent as well as of the child. And you can see on the bottom, these are old data, really looking at the rates of substance use in pregnancy do not differ by race. The rates of reporting do. And whereas like in the 1990s, it was 10-to-1 reports of Black to white, pregnant people, In 2011, it was more like 2 to 1. So there's a narrowing of the racial inequity, but this to me illustrates the difference between equality and equity. Reporting everyone isn't exactly the world I think we think of from a social justice perspective. So to borrow, from Nancy Krieger, that which does not reside in the body resides in the body politic. And to be clear, the assessment of substance use during pregnancy from a drug test is not clinical care. It's not diagnosis, it's not prevention, it's not treatment. In fact, that tool, the tool of the drug test, undermines clinical care and generates legitimate medical mistrust. And there's a conflict that providers have between the provision of health care and mandatory reporting, and working in an environment in which our values do not align with that of the institution or within that of the legal framework is precisely how moral injury happens. And these are two, statements from two different professional societies. One, the American Society of Addiction Medicine, that, highlights how equating a positive drug test with child abuse is scientifically inaccurate, inappropriate, and can lead to an unnecessary punitive approach. And the right-hand side, this is a statement from the American College of Obstetricians and Gynecologists that calls out provider culpability of what they call test and report, and really illustrating the proximity of clinical care to policing during the birthing hospitalization. So generally speaking, knowledge in this area of drug use and pregnancy, we generally speaking exaggerate, the harms of illegal substances and minimize those of legal ones. In other words, we reproduce a social and legal classification onto biological and public health, quote unquote, harms. We also overstate the importance of intrauterine exposure and neglect the role of the caregiving environment. And I think the data I showed in the very beginning, we know how to care for addiction in pregnancy and outside of pregnancy, but we rarely do that correctly. So there's a gap, between what we know what to do and what we actually do. And there's also gaps, in professionalism and over-reporting to child welfare based upon misinformation amongst healthcare professionals. There are gaps in critical thinking and communication, around like what the actual consequences of in utero chemical exposures are. And I just want to repeat this, that really like this gap, in this episodic care for the chronic condition of addiction, reflects in how we provide insurance, reflects in how our workforce is structured. And, we think of addiction as a chronic recurring condition, which it is, but any condition to which we only provide episodic care will be chronic, relapsing, and remitting. So the real big picture is that healthcare is not safe for people who use drugs. And I think we should think about discrimination as a patient safety issue and fold it into the work of things like the perinatal quality collaboratives that are well aligned to address quality improvement. In other words, structural problems require structural solutions. And part of that is to decriminalize the healthcare setting, to pay attention to how we collect and share information around drug tests, that can be used to report and ultimately punish people, but also around other reproductive health information, which can be used ultimately to report and punish people. And the other big picture is to really decouple drugs from development, to try to focus on, the dyad and on development. And I think one way that we do this is by changing the questions we ask. And this slide and this concept is indebted to Dr. Andre Jones. And really the old questions, what proportion of people use drugs? What are the consequences, which we always assume to be negative? Some of those are, helpful from a surveillance perspective. Some of them are unanswerable, but they're not as important as questions such as what do families need to thrive? what interventions enhance early childhood development, and to what extent do the policies that we enact not just improve health, but yield equitable outcomes, for the person, the fetus, the neonate, the child, and the community. Thank you.
Thank you so much, Dr. Turpelin, for that great presentation. We have not heard yet today about substance use disorders and maternal health as extensively as you just presented them. So that was really very helpful for the panel. I will now turn it over to Barbara Larea to talk about implications of stress, food insecurity, and weight status on the course of pregnancy and outcomes.
Good afternoon. I want to thank the organizers for putting together this fabulous workshop. I also am really inspired by all the talks that we've had so far. So I'm Barbara Larea. I'm a professor at UC Berkeley School of Public Health, and I will be talking about stress, food insecurity, and weight status in the course of pregnancy and outcomes. There we go. Are you advancing or am I advancing?
You are.
Okay, good. So I have no disclosures. And I first want to acknowledge that there is a wide and vast literature that focuses on pre-pregnancy weight status as well as gestational weight gain, and its implications on the short and long-term health of birthing people and their infants. However, I really want to focus on the social determinants here, and those are all the conditions that really create an environment that helps individuals with their weight status. And so that's either underweight or overweight or obesity. And namely the socioeconomic and political, the policies that we have. And we have a number in our toolbox. WIC, for example, that really helps with nutrition referrals and actual food, as well as a number of poverty alleviation programs such as SNAP, the Earned Income Tax Credit, and Child Tax Credit. And these have all been associated with more advantageous birth outcomes and assistance to pregnant people. There's also a number of policies that we have that have really created poverty and inequitable access to lots of resources. And there is also policies that we really need to focus on, such as federal paid maternity leave and paternity leave. We're the only country that doesn't have that among our contemporaries. So having said that, what I want to focus on is really thinking about weight during pregnancy and how it must be viewed within the social determinants of health framework. And I'm going to talk about food security, stress, and depression today, because those are all three key exposures that influence what we eat, how we eat, our nutrition and eating behaviors, as well as how food is metabolized. And then after 4+ decades of focusing on weight, specifically overweight and obesity, we have now the unintended consequence of weight stigma, and which is a real problem today in healthcare. All right, I'm going to begin just with a study called the MAMA study. This is a 8-week stress reduction, mindfulness-based stress reduction intervention that we conducted in the Bay Area. And we really aim to reduce stress and depressive symptoms, and increase awareness and hunger and satiety cues. This intervention, as I mentioned, was 8 weeks. It's based off of John Kabat-Zinn's mindfulness-based stress reduction program. And we integrated Jean Christeller's MB Eat, which is a mindfulness-based stress reduction that focused on reducing binge eating disorder, as well as Cassie Veaton's Mindful Motherhood, another 8-week mindfulness program. We enrolled 215 pregnant women who were overweight or had obesity, and this was a multicultural group of women, and they were all of medium or low income. We recruited women before 20 weeks gestation, and those who were eligible but past 20 weeks gestation became part of the control group. This was, as I mentioned, 8 weeks. They were 2-hour classes, and it was met with a lot of satisfaction. Women loved that we were focusing on reducing stress, not counting calories. And what we found is that in addition to being of middle or low income, we found that many trauma, stressful events, and food insecurity kind of coexisted in this group of women. Very high prevalence of each of these, especially food insecurity, with 59% experiencing some level of food insecurity, either worrying that food would run out or actually reducing the amount of food that they ate. 3/4 of the participants, either in the intervention group or the control group, experienced one or more of these stressful events. So this is, you know, much more of a crisis than we were realizing. We did find, though, that the women in the intervention group did score significantly lower on perceived stress, depression, and much higher on this construct of awareness, which is acceptance and action, a measure of psychological flexibility. We also found that the mindfulness group on average gained actually below the IOM recommended guidelines. In a post hoc analysis, we found that all of the women gained some amount of weight, no one lost weight, and none of them had an adverse birth outcome. So it's possible that this stress reduction intervention is really improving not only psychological flexibility and reduction of stress, but improving metabolic pathways, which was our primary hypothesis. We also found that on average, women in the intervention group had a lower oral glucose tolerance test, and they also were less likely to have a score of above 130 on oral glucose tolerance test. So it reduced insulin, improved insulin sensitivity. Okay, so now I'm going to talk a little bit more about this issue of food insecurity that's so prevalent. Our best estimates are that 23 to 28% of pregnant people have some exposure to food insecurity at some level. So this is on par with the prevalence of obesity in this group. But we don't have a surveillance system in the United States or consistent screening. In California, we have the MIHA study, the Maternal Infant Health Assessment Study, and this is our version of PRAMS, which I'll talk about in a moment. And we administer a 6-item scale for food insecurity, and it goes from the least severe question, worrying that food would run out, to the most severe. And I've highlighted question 4 here. During your pregnancy, did you ever eat less than you felt you should because there wasn't enough money to buy more food? And so this is a more severe question, and this is the optional question that other states in the United States can use. We found that women or pregnant people who responded to the MIHA study and who were food insecure were much more likely, there's a much higher prevalence of having and reporting depressive symptoms, losing a job, having no social or emotional support, domestic violence, being separated or divorced during pregnancy. So the point is that all these issues co-travel, and food insecurity is something that we should attend to because of the high prevalence, and it could help us identify other risk factors. So recently we just conducted an analysis. So this is very preliminary findings that I'm showing you today using the Pregnancy Risk Assessment Monitoring System. This is what other states use across the United States to represent live births in their state. And it's administered through the CDC at the state level. So it's publicly available data. I I have the link here. I encourage everyone to use it if you're interested. In the most recent waves of this, 2016 to 2022, we collected the data, and we find a very high prevalence of preterm birth, 17%. This is really kind of outrageous. Also high prevalence of small for gestational age, large for gestational age, 9%, and of that 1% with macrosomia. So only 10 states elected to ask this one item question. During the 12 months before your new baby was born, did you ever eat less than you felt you should because there wasn't enough money to buy food? And 9% of the respondents said yes. This is probably a grave underestimate of the full range of food insecurity, but we have this one question that's more severe. And we found that in adjusted models, not having enough food was associated with inadequate weight gain, a higher odds of inadequate weight gain, and it was associated with a lower odds of large for gestational age and macrosomia. So the concern here again is, what is stress and food insecurity, which is a major stressor, doing to one's metabolism? While we don't want a high prevalence of infants born large for gestational age, this is not how we want to arrive at this. So we really need to attend to stress, depression, food insecurity as a major stressor to address some of the pathways that are happening. And finally, I want to talk a little bit about weight stigma. Weight stigma is a newer research area. It's growing. This is just a quick PubMed search of weight stigma in pregnancy, and we're seeing more and more studies come online. 60 to 70% of pregnant persons say that they have experienced weight stigma during their pregnancy. Weight stigma has been associated with stress, depression, disordered eating, emotional eating, high weight gain, postpartum weight retention, and negative prenatal experiences during pregnancy. So while we've done great jobs, myself included, analyzing and studying how weight and weight gain and obesity might influence the pregnancy process, there is this major unintended consequence. So connecting the dots, weight status and weight gain are sensitive topics, and they should be viewed in a social determinants of health framework. A substantial number of birthing people face food insecurity and additional hardships, depressive symptoms, and weight stigma. Each of these influence dietary intake, eating behaviors, and metabolism. Weight stigma and challenges with how best to address weight during pregnancies are barriers to pregnant people's health and well-being. And we need to address the person holistically, attending to social determinants, mental health, and basic needs. So my recommendations for research moving forward is really trying to understand how we can completely eliminate food insecurity during pregnancy. There's really no need that pregnant persons go without food. And work with the birthing and postpartum population to inform approaches to these challenges. We really need to include the community that we're serving. We must, in our research, really focus on structural determinants, namely income inequality. I think this really is the big issue in much of this research, and also dignified healthcare. Research needs to be conducted on what's the optimal amount of an income cash transfer, for example, intervention, or how can we improve SNAP or WIC benefits to really meet the needs of families, and improve, as we've heard often today, the adequacy of referrals for mental health. I love the idea of group care and adding some of these tools to that. And then more research really needs to be done on coming up with and implementing training for healthcare professionals that address fat phobia and weight stigma. And I just want to end by acknowledging the Mamas team and the participants, my collaborators, Alyssa Eppel and Cassie Veaton, and colleagues Pat Ocampo, Lynn Messer, Irene Yen, Barbara Abrams, and Natalia Smith. Thank you.
Thank you, Dr. Lara. That was a great presentation. We are going to have a lot to talk about during the discussion session. And to that point, I just want to remind our speakers from this session and even previous speakers today that we are getting a lot of questions in the chat from our audience. We might not be able to answer them all during the discussion session. So speakers, feel free to go in there and just type in responses in the chat. Okay, now we will hear from Dr. Allison Stubbe, our last speaker in this session, before we hand it over to our panel chair to run the discussion session. So if we could pull up Dr. Stubbe's slides, we will get started.
Thank you all so much. It's really an honor to be part of this amazing team of folks. And I think we're all saying in many different ways that we need to fix the system, because it's not the mamas who are a problem, it's the systems that we're trying to serve them through and with. And so we need to do better. So with that in mind, I have a couple of disclosures. I have some technology I've developed that I'm not going to talk about today. I've received grant funding from a number of different sources, but I think most importantly, I'm a parent. I have 3 children, and so I have lived experience of my own birth and postpartum, and I think it's really important to appreciate that all of us bring that personal experience and expertise, and sometimes deeply felt negative experience when we talk about these issues. And so I think that's important, both because those lived experiences inform solutions, but also because sometimes those can color our opinions and understandings of other people's experiences. And I worry as a clinician when I walk into a patient's room and she talks about the baby not sleeping and I start giving her advice, I'm reflecting on my second child that doesn't sleep through the night as an 18-year-old rather than on the actual science. And so I think it's just something important for us to recognize is the personal experience we bring to all of this. So without further ado, I want to talk a little bit about a life course framework for maternal comorbidities and adverse outcomes, apply a reproductive justice lens to prenatal risk assessment, and then talk about some specific examples of upstream approaches to addressing these structural determinants that patients face. So beginning with the concept of a life course. This is adapted from a couple of different graphics and papers, one by Joy Perry and another by Dr. Kramer and colleagues, to think about how we get to the adverse health outcomes. And so what this reminds us is that the root causes of the disparities we see go back to chattel slavery, to Jim Crow, to redlining, to settler colonialism and its impacts on Native American populations. And those root causes have led to structural determinants of health that affect community environments and then affect health and well-being. And they affect both the options that individuals have to make before, during, and after pregnancy, and then also they're embodied in cardiometabolic health, neuroendocrine health, and immunoinflammatory health. And so many of us have talked about this in different ways today, but I wanted to bring this framework to the fore for my presentation. So I think the other critical piece, and we've heard this lots of different ways, is that poverty is hazardous to your health. And this is just one example of a paper that looked at social disadvantage and adverse offspring birth outcomes. And you can see there are lots of different mediators in the middle here, but social disadvantage is the driver of antenatal substance use, of maternal health conditions, of psychosocial stress, which then lead to adverse birth outcomes. And so if we want to get better birth outcomes and better postpartum outcomes, we need to go back and address the system and think about how we construct a society where social disadvantage is not such a powerful predictor, or it is not present, I suppose. So I want to take that to a specific example. This is a paper that looked at hemoglobin A1C during pregnancy for individuals with pregestational diabetes and birth outcomes. And they found that those who had good or improved A1C over pregnancy had much better outcomes than those with poor control over hemoglobin A1C. So one version of this story is patients should listen and control their glucoses, and then they would not have bad birth outcomes. But I want to take the concept of glucose control and go back to this map of root causes. So root causes, slavery, 13th Amendment, Jim Crow, lead to food instability and difficulty accessing care. If you live in a red line neighborhood, there are fewer clinics than there are if you live in a well-to-do neighborhood. Those in turn affect transportation, trust in the healthcare system, interpersonal racism. These things lead to untreated diabetes, which gives you a high A1C in admission and then affects your ability to control that during your pregnancy. So Although obviously it's important to notice if someone's A1C is elevated and to adjust their insulin and to show them how to do that. If we don't think about the constraints that are affecting whether or not they can adhere to that plan of care, we're not going to help them get better. So with that in mind, I want to also think about how to apply a reproductive justice lens to prenatal risk assessment. And Dr. Bridges, who's been a shero of mine for a long time, I was fangirling like crazy to hear her talk today, presented to us reproductive justice really beautifully earlier today. But I think it's important to think about how we approach screening. And this is from a paper by Karen Scott and colleagues, where they note exclusively addressing individual behaviors as the basis for health outcomes without a structural perspective can lead to stigmatization, scapegoating, heightened surveillance, and criminalization, all of which disregard the bodily autonomy of pregnant women. And I think that Dr. Turplin laid this out beautifully with the discussion of substance use testing and its effects on relationships with the Child Protective Services system, or the child policing system, as Dorothy Roberts describes it. And so I think that when we screen for social determinants of health, the sort of questions that are in my EHR are, do you eat healthy food? Do you exercise regularly? And there are questions about food security, but there's nothing about, is there a place to walk in your neighborhood? Or do you have to work 3 jobs to pay the rent? In which case you are not getting regular leisure time physical activity, not because you're making bad choices, but because you don't have choices. And I think that's really important to consider. So work led by my colleague Kristen Tully at UNC, we looked at how to do patient-centered screening for social determinants of health. We did human-centered design workshops, we interviewed patients, we interviewed care providers, and we put together this paradigm that I'll walk you through. But there are a couple of core concepts. One is to be strengths-based. To echo Dr. Turplin quoting Andre Jones, we should ask what's going well, not just how are you broken and how can I, the all-powerful healthcare provider, advise you to fix it. We need to normalize use of community supports as self and family care and acknowledge needs as dynamic. We need to include resources of referrals. Don't ask if we can't help. And I know there was a discussion in the chat earlier about screening for depression, and even if we can't refer, knowing how many people have depression can help us advocate for better care. But let's think about what happens if the patient discloses that she's experiencing depression and anxiety, and we're like, gee, that's a bummer, I can't help you. We need to have something to offer if we're going to ask these very personal questions. Engage actively with the patient's descriptions of their lifestyle goals and needs. And we need to design information so patients can get resources and information on their own, not that they have to tell us that something bad is going on before we can provide them resources. So in the next slide here, we break out this, we start in clear language. Have I shared all the resources I can without screening? And if not, tell the patient about the resources. Don't make her tell us or make them tell us that things are bad. Do I have resources that can help? If I don't ask. If I do, are the patient and I fluent in the same language? And if we are not, call an interpreter. Do not pass go, do not collect $200. If yes, explain the purpose of screening, ask the patient for their permission, talk about how the responses will be used, how long they will be stored, where they're going to be, and who has access, and make sure the patient knows they don't have to answer. And then screen the patient, and then provide resources and referrals. So I think this is very different from how the SDOH screening questions get handed to patients at the front desk in my own institution and in lots of other places. And I think we need to be really thoughtful about how we're doing that. So then what does it look like to really go upstream with intentionality? This is a really wonderful approach that was developed by the Racial Equity Institute in Greensboro, North Carolina. And they talk about this groundwater approach. And the metaphor they use is, imagine you're going for a walk and you come upon a lake and you notice a dead fish. If we see a dead fish, we might think, gosh, what's wrong with the fish? Did the fish eat something bad? Did the fish make bad choices? Did the fish not adhere to their doctor's instructions? But we think that the fish is the problem. If the whole lake is full of dead fish, we're probably going to not think about fishes making bad choices. We're going to think about the lake. And if all the lakes in our community have dead fish in them, we're going to think about the groundwater. And so much of clinical care and the paradigm of Western medicine is about fixing the fish instead of recognizing that if the lake is toxic and the groundwater is toxic, we're not going to be able to get to a solution. And so I think it's critically important that we interface with and collaborate with partners across all disciplines, including our colleagues in public health and anthropology and social sciences, to think about the groundwater. Because we can fix all the fish we want, but if we put them back in the lake and the lake is poisoned, we're not going to get where we need to go. And I think these two authors have put this really beautifully in an essay on health affairs, talking about the emphasis on social determinants. And we understand that medical interventions are not enough, but often our social determinants of health screening is, oh, you're hungry, let me give you, here's the address of a food pantry. Or, oh, you're hungry, here's WIC. But not, oh, you're hungry, why does your community not have a job where you can earn a living wage, and how do we change that so that you can afford food, instead of just sort of patching over the problem? And so we can't really fix these issues until we make a commitment to go upstream and change the community conditions that make people sick. And I think there's another wonderful essay that I came across after making this presentation where the author, who's a social scientist at the University of Michigan, whose name is not in my head right now, says that, we need to recognize that all of the individual interventions in the world are not going to fix the inequities that are causing people to have these unmet needs in the first place. And so we need to be really intentional about going upstream. So I think this is a really interesting example of a social determinant of health that Saron Wheeler and colleagues at Duke interviewed folks in a preterm birth clinic about their experiences with their employers. And this is what one patient shared. I was just laid off yesterday. Due to my limits and restrictions from the doctors, I was put on a 10-pound lifting limit, which is very, very small. And unfortunately, with all the job descriptions at my employer, I wasn't eligible for employment anymore. I busted my butt at that place and gave it everything I had, even very sick and ill and not well. And I feel like they tossed me in the trash. So here's a doctor trying to do the right thing and say a patient high risk of preterm birth shouldn't lift heavy things, and the patient is now unemployed. And so one of the opportunities here is to pass legislation. So this is a presentation put together by Black Mamas Matter, where they note that while no single piece of legislation can end the systemic racism that contributes to the Black maternal health crisis, policies like the Pregnant Workers Fairness Act are an important step in addressing Black pregnant and postpartum people's health, safety, dignity, and economic security. So if the Pregnant Workers Fairness Act were enacted, you couldn't fire people who were pregnant who needed accommodation. That would be a federal law, but that doesn't exist right now. And so I think these are the kinds of changes that are really important to address larger issues. And then I think another really great opportunity is to think about medical legal partnerships. So medical legal partnerships help to build an integrated healthcare system that better addresses health harming social needs by leveraging legal services and expertise, both to advance individual and population health. So this is a little bit of fixing the problem. The patient comes in and says, my boss is going to fire me because I had a prenatal visit. And they can say, well, actually, that's illegal in this state. Unfortunately, I don't think it's illegal in North Carolina, but it is illegal in some states. And the medical legal advocate can assist with this. So this has been enacted at Georgetown in the Health Justice Alliance Perinatal Law Clinic. And these are some metrics of the kinds of services and solutions they were able to secure for folks simply by providing that free legal assistance to make them aware of what's possible. Importantly, though, a medical legal partnership is not just, I'm going to fix your individual issue, but the folks who run these programs identify trends. And if they find that one employer has done this for multiple people, or that multiple employers are not aware of employee rights, they can take that to the organization and say, hey guys, you're not doing this right, and let's talk about a mitigation strategy, or let's pass the Pregnant Workers Fairness Act to make this illegal because it's inappropriate and it's adversely affecting health. And then this is just one more example of a medical legal partnership in a pediatrics context that had a really profound impact. Through Cradle Cincinnati, in Cincinnati, at pediatric visits, folks answer screening questions asking, are you having problems getting your WIC? Is your housing overcrowded? Roaches, rodents, utilities, mold, lead? Have you been threatened with eviction? And then also questions about mood. And so through this screening, they were able to appreciate that multiple houses here had problems with lead and rodent infestation and mold. And it turned out that the same landlord had bought a bunch of low-income housing in Cincinnati and let it run into the ground. And so the medical legal partnership leveraged resources and sued them and got it fixed. And so they were able to address both the individual apartments of the affected children, but also the other people who lived in the same community in order to target upstream social determinants of poor health. Now, the really upstream is that we don't have low-income housing because people have incomes and they can afford better housing. But I think we can really be intentional about not just fixing the patient in front of us, but starting to look at the lake or ideally the groundwater. And so I would close with this quote from Joya Perry, who's one of my sheroes. What would it look like for mothers to not only survive pregnancy, but to thrive? Thank you.
Thank you very much, Dr. Stubbe. I will now turn it over to Dr. Davidson, our panel chair.
Thank you, everyone, for those really interesting talks. As usual, I'll start by asking if the panel members have any questions or comments or follow-up for this particular roundtable. John.
So I have a couple about the evidence report. There's been a lot of information, so pardon me. Because the categorization is at some level the primary objective of this evidence map, we talked about the categorization of the evidence being somewhat subjective, which you described nicely in the report. To what extent, and I know you can't do a sensitivity analysis really because you're not doing any sort of qualitative analysis, but to what sense did you experiment with different categorizations of the evidence and or maybe recategorization of some of the evidence to arrive at different groupings? What was there any thought given to the impact of how you categorized and grouped the evidence?
Jamie, if it's okay, I will field this one. There actually were not a lot of ways to do that kind of sensitivity analysis because they were, either strongly differentiatable or the types of factors that were being looked at sort of agglutinated in particular spots relatively clearly. And we did, take a look at, we had gone in thinking that it would be, we would try to do more with some intersectionality, such as race and rural or race and, some other kind of thing. But there it started to become fairly challenging. And so so the short answer is we did not do any. The longer answer is it's not for desire, lack of desire.
Sure.
Yes.
A bit of a follow-up, can I, Karina?
Please.
The measures of identity and discrimination, I want to understand. You talked about reporting of discrimination or racism was that's what you took as that's what you understood the one of the variables to be. And I want to know if in this section was it self-report of identity and discrimination, or were there some other validated measures that were used to group this group?
Yeah, this one is fairly wide ranging, and again, we're limited by the databases that collected the information and the studies as they reported them. So this became sort of the catch-all category that really tried to speak to the individual's experience, whether they were claiming a label, whether a label was being applied to them, whether it followed an appropriate categorization that would have been widely agreed upon or not widely agreed upon. So if there were questions of experience of racism, it's there. If there were questions of the experience of acculturation, it's in there. If it's the specific race or ethnic categories and labels that were used, it's in there. So it's trying to speak to it from that individual's place and perspective.
Gotcha. That helps. Thank you.
Jamie, I didn't know if you had anything you wanted to add. I'm going to guess not then. Allison, I would like to follow up with a difficult question for you. I have struggled with figuring out how one could systematically find those upstream interventions, demonstration projects, out of the box thinking that started to address the social determinants of health that may lead to more reproductive justice. And I stumble across them, but I've never been able to back engineer to what keywords, what search strategies we would all collectively use to start getting our arms around some of these incredibly important demonstrations of ways that we could improve the health, both of women and their children. Do you have any thoughts of that, given some that you were sprinkling examples that you had seen? Maybe you could tell us how you collected those and offer some insights into what we could be doing going forward.
I mean, I think it's hard because this is the kind of work that doesn't, I mean, there's not a keyword for it, right? I was fascinated that there is no postpartum health category in the NIH subject matter research. So hopefully we're going to fix that after this meeting. I think that some of it is reading and learning, and then I think we need to think about taking a positive deviance approach. Elizabeth Howell has called for this in a really nice commentary in Seminars in Perinatology, I think. So positive deviance is an approach that's been used in global health and in nutrition for a long time, which says, rather than saying, who's having bad things happen to them and let's find out all the badness about them, we say, well, in a group that's at high risk of morbidity, who's having a good outcome anyway? And then try to understand what's working there. And so I think that, we have all of these data sets of social vulnerability index, SVI down to the census tract level. Well, what census tracts have high SVI, but low rates of preterm birth, or low rates of severe maternal morbidity, or low rates of preeclampsia? And what can we learn from those communities to understand what might be the secret sauce? Because that kind of tacit knowledge of community level solutions is probably going to work better than anything that we come up with on a WebEx. And then I think it's really about listening to the folks with lived experience. And I think community birth workers are doing amazing things every single day. And, figuring out how to put them, how to add them to this very broken system we have right now in ways that allow them to earn a living wage and do their magic is part of the systems challenge. But I think listening to the folks who are figuring out what works and taking a more deductive approach could be really important. And then I think there's sort of a medical librarian question of how do we find those? Because there isn't, I don't think social deviance is a keyword. That Improve Initiative Maternal Health Research Center for Excellence is due on Monday. Happy Thanksgiving. I don't know who else is trying to put that together right now, but I'm doing a lot of literature searches, let's just say. And positive deviance is one of the things we're including, and I don't think it's got a keyword, but that's about sort of figuring out how to flag that and build it out. So I don't know if that answers your question.
It does. I too have come across where entire communities have fixed pediatric asthma problems by having crowdsources of what are all the structural issues that need to be changed, and then getting state grants in order to fix it. But, finding how we can empower the people around us to find those examples and know what are the levers to push for the problem that they're having, I struggle with constantly.
And I think that, Cradle Cincinnati has done really impressive work, and they've done hotspot mapping of communities and figured out what kids are being hospitalized, and then they've developed strategies around that. And so I think some of it is we're still kind of doing, if John Snow were using our current approach, he'd be treating everybody for their cholera and wouldn't have asked where their water came from, and they would still have cholera, right? We are not looking for where the water source is that's the problem in a systematic way. And then when it's there, we're not turning it off. We're writing a paper about it and being like, there seems to be a bad water source here. And so I think we really need to figure out how to go from data to action.
Yeah, and what I was asking, which I knew was an impossible question to begin with, some people have gone to action. So in the pediatric asthma project, they mapped where trucks idled, and they moved those trucks because there was places that were off ramps that were convenient, that, as some of our earlier speakers pointed out were in zip codes where there was high poverty and where it was okay to idle. But getting that lesson across to other people, I think, is one of the tasks we as panel members have. And we're just hearing from each of you incredibly insightful individual instances of getting at those structural problems in creative and innovative ways, but embracing how we systematically find all of those cases, I think, is difficult. I do have a question posed for Barbara. What are your, this is from the audience, what are your thoughts on how internalization of weight stigma may interact with food insecurity in pregnant persons?
I thank you for that question. I attempted to answer that in the chat, but weight stigma is really highly associated with all these metabolic indicators such as stress and depression, but also developing an eating disorder and emotional eating. Food insecurity also can play into that. So we have a perfect storm when women are stressed or pregnant people are stressed, and then they desire the highly palatable food, they reach for the highly palatable food, and then in pregnancy you're supposed to gain weight, so it's this struggle. And so that's one way. And when we eat food under stress, even nutritious foods, it can be metabolized and stored as visceral fat and in all the wrong places. So it's not just the eating the food, it's also how food is metabolized. I think I froze, but did you get the end?
Yes, we did. No, you were clear all the way through. I see many people have in fact been addressing questions and comments in the chat, so I very much appreciate that. I'd like to take these last couple of minutes and ask the panel members if you have questions that, the workshop members for this roundtable, if you have questions for each other or comments on each other's work.
Dr. Davison, to sort of try to answer the question that you posed, to Dr. Stevie,
Sure.
I think some of it really relates to sort of challenging, like the ideology with which we like frame questions initially, and thinking about how the care environment, how the research paradigm, how the collection of public health, surveillance data reproduces, a particular, ideology of like personhood and culpability. And I think some of it, there are lots of examples of data and research and people's careers that have, challenged the dominant paradigm. And the example in my space that I turn to is that of like Halam Hurt, who's a pediatrician, who was one of the first people to get a grant to look at the effect of IQ at 2 years of age due to in utero cocaine exposure. And she found no difference by cocaine exposure, but found a range of IQs amongst the participants, all of whom lived in extreme poverty in, segregated West Philadelphia, almost all of whom were Black. And her research shifts, interestingly, from sort of drug focus to developmental focus. And she does sort of operationalizes the home visits and identifies aspects of childbearing and environmental context that are associated with higher versus lower IQ. And to me, that's like, her career goes in a different direction and goes away from sort of these assumptions of harms of substances. And so to me, that's an example of the type of work that has happened, that is possible, that's across all the fields that we work on, which won't be identifiable by, like a mesh heading.
Yep. Yeah. Agree. Thank you for that helpful comment. I know Dr. Terry from the panel has a question.
Hi, can you hear me okay?
Yes, we can.
Great, thank you. Today was really fantastic. Thanks to all the panelists for their amazing talks. I wanted to just follow up quickly on the evidence report and make sure that I understand it correctly. Again, it was so comprehensive and really super helpful. I think unless, and please correct me if I misunderstood the presentation and reading it, but of the studies that you found, none of them would have met the criteria by Robbins to rule out bias for any of the associations. And I was wondering if you could just comment on that. Was it an issue of how the questions were framed, as has been discussed most recently in this last panel? Was it a question of just how the data were collected, or was it more a question of how the data were analyzed, if that's possible? Or did I misunderstood that none of those met that criteria?
Or we could say all of the above, depending on which particular paper that we would be looking at. So, so yes, all of them would struggle to meet anything less than a high risk of bias in terms of our ability to trust its results from a causal standpoint. There was associational work that was looked at, but because of concerns about selection bias, because of concerns about analytic approaches, because of concerns about the potential for unobserved variables that would be very important, because of concerns about essentially all of the categories that contribute to a Robbins I, and the Robbins E is still in a little bit more of a developmental phase, but it's based off of the Robbins I, which is specifically created to be able to address the types of questions that come up with observational types of research approaches. So all of the literature struggles to attain that type of ability to answer a causal question from from a strong sense or even a moderately strong sense of confidence around it. And unfortunately, there isn't really good methodology yet developed for being able to assess a body of evidence, like in these particular reports. All of our strength of evidence approaches that rely on this type of risk of bias assessment are designed to answer causal questions. And so they're not well designed to address risk factor or predictive research. And so there's just we have an extreme caution of wanting to apply it where it would not be appropriate.
Thank you.
Does that help?
Yeah, that's very helpful. So, and I apologize for not being super familiar with the tool, but just so I guess I'm clear. So if there were data like a difference of analyzing state policy, I think California has had the longest time with paid family leave. Would that be like a study design that would meet like a causal framework, or?
Potentially, but then there are so as a design approach, it's a quasi-experimental that is trying to take that causal perspective to it, but there are all of the other elements that go into it, and oftentimes there can be issues again around the data itself, the availability of the variables to actually capture the types of questions that you have, the plausible alternative explanations that are maybe omitted variables that we just simply cannot address. And so it gets to be very challenging. And we really appreciate how clearly in the literature, there is a trend towards trying to use these more advanced techniques, and really appreciate the effort that's being taken to try to bring the research to that level. It's very hard research. It's very hard analytic research to do. So our sympathies really lie with the people who are really trying to take this field forward and into a stronger level of causal rigor.
Thank you so much.
Thank you. I've got a couple more questions from the audience for Dr. Stu, but can you share your thoughts about strategies that would enhance the training of U.S. lawyers that would support their readiness for medical legal partnerships that would then support postpartum populations?
So as a physician at a medical school, I will tell you that I'm in close contact with somebody at the law school for a grant that we're writing to develop a medical legal partnership model in maternity care in conjunction with Legal Aid of North Carolina. And so I know UNC has a JD MPH joint program, and one of the folks who's going to be working on this project has a JD and an MPH. So that gives you the legal and public health piece, and she's doing work for Legal Aid of North Carolina right now. So I think that, I know that the program that I cited at MedStar is run by Georgetown Law School. And so I think law schools and medical schools working side by side to bring law students who are interested in social justice into the clinical setting is a really good way to kind of cross-pollinate, and then also to educate us as clinicians, because I know ACOG put out a statement about writing the work letter, that if you write may not lift more than XX pounds, in a lot of states, the person can be fired. And so you need to word it really carefully. And again, we need to change the law, but we also need to make sure we're not pushing people, we're making things worse. And so I think that those kinds of educational opportunities are really important to make sure that, not that I become a lawyer, but that I have a friend who's a lawyer. And that, the lawyer doesn't become an obstetrician, but can collaborate in that way. I think it's funny because when you search for medical, legal, and pregnancy, everything is about risk management. So I'd like to change that paradigm and have it be about medical legal support for pregnant people as opposed to lawyers suing obstetricians. So.
Wonderful. I'm going to ask my last question. Food insecurity, food deserts, public school lunch programs, incarcerated food for incarcerated persons. What are we feeding our institutionalized populations, and how does that impact their maternal morbidity and mortality?
That's a great question. I think the quick answer is it's a wide range of food that's being offered, and it really depends on the structure that's providing the food. Obviously, wealthier areas are going to provide more nutritious foods, and there's a lot of experiments going on right now with providing nutritious food and decreasing plate waste. But we have a long way to go in the prison system and with many schools. So there's active work. We have a long way to go, but it's a fabulous question.
Okay, well, I'd like to once more thank the roundtable speakers on Key Question 1. We really appreciate your deep insights into a variety of issues. I know we didn't speak about substance abuse, I think, as much as we should have, but we certainly will be considering that at the panel. I'd now like to hand this over to Diana Bianchi to close us out. So please, I know it'll take us a moment to get your slides up, but I'd like to turn the mic over to you.
Thank you very much, Dr. Davison. Wow, what an amazing day it's been. There's been so much rich content, and I know we're all taking notes on what we've heard. I especially appreciate the engagement of the audience. I know that we're going to capture the chat box and all of the publications that are in there. So I appreciate you hanging in there for just a few more minutes. I have the tough job of following so many great speakers. My job is really to just tell you a little bit more about what NICHD is doing. I'm the director of NICHD and have been for 6 years. I am one of these people that straddles fields, so originally trained in pediatrics, neonatology, and medical genetics, but my research is in prenatal genomics. And it's really been a privilege to lead NICHD through the strategic plan, which really emphasized the component of reproductive health, which accounts for about 30% of our portfolio. So am I doing the slides, or could I have the next slide, please?
Certainly, I'll switch them for you.
Thank you. So speaking about the strategic plan here, it's amazing that we're almost getting ready to do another one. But this was the first strategic plan that NICHD had in over 20 years. And we thank those of you who participated in the planning of that. We originally started with over 270 different scientific research themes and then ended up with 5. And the point of this slide is to share with you that 3 of the 5 clearly highlight reproductive health and the fact that a healthy pregnancy really sets a pregnant person up for lifelong wellness. Furthermore, I know that some of the speakers have talked about PregLac, and NICHD was asked to lead the PregLac initiative, and we are constantly communicating updates on how we have implemented some of the recommendations in PregLac, which I'll mention a little bit later. But one of the things that came out of that was the need for safe and effective therapeutics and devices and vaccines that have been appropriately tested on pregnant and lactating people, children, and people with disabilities. So the PregLac language, the appropriations language, really used the term women. And of course, that was in 2016. So when you see women, we mean all pregnant people. Next slide, please. I don't, after the whole day today, I don't need to really reemphasize the fact that preventive care, but this is a conference about prevention, that this is key to optimize women's health before pregnancy. But we have funded some research, which unfortunately is not published yet, but was shown at a poster at a recent meeting that indicated that if a person is hospitalized anytime pre-pregnancy, that this is associated with severe maternal morbidity postpartum. So this indicates a particular point in a person's lifespan at which we could intervene to prevent maternal morbidity postpartum. We have a ton of research, some of which has been quoted today, that verifies the importance of good prenatal care. We know, and we've heard today, that access to care is not equal. Birthing persons enter prenatal care at various times during the pregnancy, and in some cases not at all. And I recognize that at least one person put in the chat that oftentimes people do not show up to appointments, and that could be for a variety of reasons, including, importantly, transportation issues. At NICHD, we're very concerned about maternity care deserts that impact upon physical as well as mental health issues. We have one right here in Washington, D.C., and that's of great concern. Next slide, please. We have, when we say the word NOSI, it's a notice of special interest. So we are often looking for opportunities that intersect our key populations. So NICHD's populations are people of reproductive age, both men and people who identify as men, people who identify as women, children, and people with intellectual and physical disabilities. So it is a natural for us to be specifically interested in people with physical or intellectual disabilities and their reproductive care or lack thereof. We know that people with disabilities do not get the same kind of care that people without disabilities get. So we do have a notice of special interest on that as a specific topic within a larger call for science on reproductive health for this population. In addition, we've been tasked with developing a research agenda to prevent stillbirth. And as part of that, we recognize that there's a significant amount of grief and mental health issues associated with people and couples who experience birth outcomes that do not result in a living child. Next slide, please. You've heard the Improve initiative mentioned several times, and again, it is an algorithm that stands for implementing a maternal health and pregnancy outcomes vision for everyone. Next slide, please. We were extremely fortunate to receive an appropriation which went to NICHD's base, but is actually an NIH-wide initiative. And I want to acknowledge here many people who are listening or participating in this webinar who have contributed to the success of this initiative, even though the budget, we didn't receive a fiscal year 22 budget until March of 22, and we had to appropriate the funds by September 30th. So everybody worked incredibly hard. And the initiative is envisioned as 6 elements, 5 on the periphery that were funded in fiscal year 22. And the center one, as you've heard about, is the Maternal Health Research Centers of Excellence. And my condolences to Dr. Stubbe, who said that her Thanksgiving was ruined. I'm sorry. Those deadlines are determined by the review dates. So we have to receive the applications to get them reviewed to be able to fund them by May. So it's kind of a backtracking issue. And all I can say is I have been there from when I was in academia. So the 6 components of Improve are connecting the community for maternal health challenge and a community implementation program. And we've heard over the course of the day some really innovative and important approaches to involving the community, using best practices of the community, incorporating culturally sensitive aspects of maternal care. There was also a dissemination and implementation notice of special interest, which allowed us to fund some grants that otherwise didn't make pay lines, but were relevant to this initiative. What I want to highlight today are the ones that are linked directly to prevention. I can't talk about all of them in a 10-minute talk. And these include the RADx Tech for maternal health, the Connect-a-thon, and the Centers of Excellence. So next slide, please. So we've been thinking about the mental image of silos. There are clearly silos between a pregnant person's life before they got pregnant, while they're pregnant, and what happens after they deliver. In addition, as a pediatrician, I've always been very cognizant of the fact that in many places still, the pregnant person's record and the baby's record are not linked. And so if we were able to have a much more longitudinal view of the life course of the particular person, just as Dr. Clayton said, that clearly would help us identify risks and help with prevention. So there has been a Connect-a-thon that was held with the aim of engaging stakeholder communities to develop electronic health record standards that will establish a longitudinal maternal health record and enable automated methods to link maternal child electronic health records for research. So the Connect-a-thon is serving as a pilot test using real-world data to establish this foundation and then to be able to use it in clinical settings for advanced data models and techniques for discovery. So this is continuing in 2023, culminating in this pilot test with select health systems and partners. And my hope is that all of you will be able to use it in the future. Next slide, please. With the COVID pandemic, one of the very successful enterprises within the money that NIH received from Congress was the RADx Tech initiative that was essentially like a Shark Tank that culminated in the development of rapid testing. And I'm sure everyone has done at-home testing now. And that technique, looking at initial technologies and helping small businesses, for example, to improve and implement the technologies was so successful that we are using it for a similar approach, but in this case to accelerate the development of maternal health diagnostics or other remote sensing technologies. So we're trying to address the problem of how do we monitor pregnant people in maternity care deserts. So people who are responding to this challenge are developing novel wearable devices, different kinds of sensor technologies or tools that are enabled by smartphones. And this particular challenge is focused on the postpartum period, which is very relevant for prevention of complications postpartum. Unfortunately, it's a little too late to participate. We're in the first round of reviewing the applications that were received. There was a very robust response. And with the different phases of the challenge, as groups make it to the next level, they get both cash prizes and they get feedback as well. Next slide. And then finally, this is the big thing, and my hope is that many of you whom we heard from today have either submitted an application or are in the final stages of perfecting their applications. I hope that there are going to be novel partnerships that develop from this opportunity. But we decided with the money that we received from Congress, and by the way, the whole Improve initiative really grew out of a challenge that the Black Maternal Health Caucus made to Dr. Collins and a number of the other directors, including myself as director of NICHD. We were not doing enough, and it really resulted in Representative Lauren Underwood being the champion for the $30 million of funding that we received in last year's budget. And because it goes into the base, that means that if NIH does get an increase, then we actually will get a little bit more money as well. The centers of excellence were really the idea, what could we do to make a difference? How can we incorporate this need for both community engagement as well as implementation research? And so there are kind of two core hubs. One is a data innovation and coordinating health and resource hub or center. That's a U24 grant. And then there's an implementation science hub and a resource center. So you can see those in blue in the center. And then the individual research sites and centers that are around those hubs. So again, we hope that I'm just looking at one of the comments in the chat. That's why I'm laughing. But we hope that we will get robust responses to this incredible opportunity and that we will really be able to move the needle altogether. Next slide, please. So you heard a little bit of a mention of PREGLAC, which was the task force on research specific to pregnant women and lactating women. We held a number of meetings with many participants from both federal agencies, a number of institutes at NIH, centers at NIH, professional society groups, advocates, pharma, importantly. And we held our task force meetings and issued recommendations in 2018, but then felt that we needed an implementation plan. It's all publicly available. If you just Google NICHD PREGLAC, you can find it. And you've heard in the ethics talk that we have truly promoted this change of culture to protect pregnant people through research instead of from research. It still hasn't percolated entirely through institutions and society, but we're making progress. Certainly the Coalition to Advance Maternal Therapeutics has really made a difference. They are really publicizing many of the recommendations from PREGLAC, and at NICHD, we have funded research, most significantly, the Maternal Pediatric Precision in Therapeutics, the Imprint Hub, which is a national resource for expertise in pediatric and maternal therapeutics. We recognize the importance of the research networks and that there needs to be a central infrastructure that will support future clinical trials. We also recognize that not only is career training and development essential, but we need to diversify the workforce, and we're very committed to that. And I bring this up because if we have appropriate maternal therapeutics, perhaps that will improve maternal postpartum outcomes. Next slide, please. I just wanted to mention the woman at the end of the table there is Vice President Harris, who is very aware of the issue with maternal mortality, particularly in Black women. And I was privileged to attend a cabinet meeting. I'm like way in the back, but in the lower right there, the man with the white mask, that's acting director of NIH, Dr. Larry Tabak. And this was a cabinet meeting that the vice president held. And I have to say, I was quite impressed at how knowledgeable and how thoughtful and intentional she was in terms of who was invited to the meeting. And in particular, the people, which cabinet secretaries were invited. Not everybody was invited. And so recognizing, for example, the need for doulas to be recognized as maternal care professionals. She had the Secretary of Labor, Marty Walsh, specifically participating in the meeting and gave him the charge of how do we create professional certification, for example, and appropriate training for doulas. I mean, so the meeting was at that level of specificity, which I was greatly encouraged by. Much of what was discussed at the meeting was related to care. The Secretary of Agriculture was also there talking about the importance of nutrition and the WIC program. Again, it was very intentional. We at NIH participate in monthly interagency Zoom meetings that are convened by the White House. Dr. Clayton and I participate in these meetings, and those meetings are held to track progress on the Vice President and the White House's maternal health blueprint. And after months of all of the work on the maternal health blueprint, unfortunately, it got a little bit buried because it was released on the same day that the Dobbs decision was released by the Supreme Court. But it was very detailed, very thoughtful. Next slide, please. I know people have been talking a lot about Medicaid postpartum coverage extension. That was another thing on the Vice President's wish list. So we just thought we would update everybody as to where the state action has occurred as of just about a week ago. I think most people on the call know that state Medicaid programs are extremely important in prenatal care. And this is the time when birthing people have contact with the healthcare system. And they often drop out after 6 weeks if they don't have coverage. So it's really good news that 27 states, including the District of Columbia, have now implemented the 12-month extension period. And another 7 states are planning to do so. And another 2 have limited coverage extension proposed. So we have to work on the gray states in this map, but we are moving certainly in the right direction. Next slide, please. So in closing, I'd like to thank the NICHD members of the P2P program, Dr. Chaktura, Dr. Chin, Dr. King, Dr. Longo, and our colleagues on the Improve initiative. And I'd like to thank the entire P2P program staff for what has really been a really exciting day and very impactful. And again, as I said, we're taking notes. My only request is if you could just leave the chat up for a few moments after we close out, just so I could read some of the comments before we close the site. So thank you, and we look forward to a great day tomorrow.
No problem. And actually, we'll be copying the chat, Dr. Bianchi, so we can send it to you. So thank you, Dr. Bianchi, for that closing of day one. We really appreciate it as Director of the Child Health and Human Development Institute. We appreciate you joining us, and we appreciate your staff, as you recognized here, supporting the development of this workshop so much over the past couple of years. So thank you. Okay, I have just a couple of closing remarks, and then we will close out the day today. It's really been a very productive first day of the workshop. So I know all of us behind the scenes here are just so excited about it. And I'm sure Dr. Davidson is too. A lot of data, a lot of fodder for the panel to discuss and consider incorporating into their panel report. So just a couple of comments about day two. If you've already registered, you should have received a reminder, including the link for the workshop tomorrow. If you haven't registered yet, you do need to register for each day. So please go ahead and do that. We'll put the link in the chat. And if you have any questions, we will also put the email address in the chat in case you're having any problems. And then I do just want to ask the 6-member independent panel to stay on for another minute so we can talk about plans for our evening call. And I think that's it. We really had an excellent day. We really appreciate everybody's involvement today. And we will see you tomorrow morning at 11 a.m. Eastern Time. Thank you.